Hmm. So, good evening, everyone. Today we will finish the remaining portion of respiratory system. So, just to overview what we have already done in the respiratory system. We have done the pulmonary function test. We have done the type of respiratory failures, and we have done the interstitial lung diseases. Now, the remaining portions are airway diseases, carcinoma of the lungs, pneumonias, pulmonary vascular disease, and pleural effusions. So today, starting with the airway diseases, and in airway disease there are three conditions: bronchial asthma, COPD, and bronchiectasis. So starting with the first disease, and that is bronchial asthma. So, what are the causes, or we can say the risk factor of bronchial asthma? First cause is the atopy, and this type of asthma we also call it as extrinsic asthma. In this type of asthma, there is atopic reactions, so serum IgE level is elevated, and this leads to involvement of many systems of the body, like skin will be involved, lungs will be involved. In skin, we can have eczema, urticarias. Then in the lungs, we can have asthma. So multiple system are affected. So individually, one particular organ will be mildly affected. Like bronchial asthma in this case is mild, and this condition is mainly seen in children. Seen in children. So it has to be differentiated from the second risk factor. We can say this as intrinsic asthma. And here the pathogenesis is the elevation of local, means inside the lungs there is IgE levels are elevated, and this is because of the pathogenesis here is could be because of staphylococcus toxin. So this can be a potential question. Infection or the toxin implicated for intrinsic asthma is a staphylococcus toxin. Then because this affect only the lungs, so it is a severe disease, severe asthma, as compared to mild asthma of extrinsic, and mainly it affects the adults. And two more important things, that this intrinsic asthma is associated with nasal polyps and sensitivity to aspirin. Aspirin sensitivity. So these usually are the differences which are being asked between the intrinsic asthma and the extrinsic asthma. Though there are other causes also, or we can say the risk factors. So if we look at the risk factor in terms of infection, so infection which predispose to the airway hypersensitivity, or we can say the bronchial hyperreactivity. So the infection implicated will be chlamydia, and atypical bacteria like mycoplasma. Mycoplasma. So these are the two atypical infection can be implicated in cases of asthma. Now there are other risk factors, and these risk factors are drugs, And the drug implicated here is acetaminophen. Acetaminophen. And remember, not beta blocker, because beta blocker are precipitating cause, not the risk factors. And of course, there is possibility of hygiene hypothesis. Hygiene hypothesis means if a patient is not exposed to the allergens in childhood, in adulthood there will be more severe immune reaction and more chances of asthma. So we can say that high socioeconomic status, more chances of asthma. And while in hygiene hypothesis there is a study which says that intestinal parasites, we can say is suggestive of a poor hygiene, and intestinal parasites, they decrease the risk of asthma risk. Then of course smoking, it is lower down in the list, but yes, it is a risk factor for asthma. And recently dietary factors were implicated for the production of asthma. And in diet, let's see what are the things which increases the risk. So asthma is increased by lack of antioxidant in the diet, so deficiency of vitamin A and vitamin C, these are antioxidants. Then deficiency of magnesium, selenium, and deficiency of omega 3 fatty acids. So these are the exact pathogenesis or exact sequence of event is not known, but they are associated with increased risk of asthma. While the things which also we can say not the decrease, deficiency of vitamin D, and of course if there is excess of omega 6 fatty acids and excess of sodium in the dietary sodium, they increases the risk of asthma, So these dietary factors are important as causative, or we can say a risk factor for asthma. Now coming to the clinical features of asthma. So clinically, if we look at the symptoms, remember this asthma can be associated with a sort of prodrome. Prodrome of, we can say, a vague discomfort, or we can say a sort of itching or discomfort. Itching over the face and the chin. So these symptoms can precede the typical picture of asthma, and the most common initial symptom of asthma is the cough. Because of bronchial hyperactivity, bronchial reaction, most common symptom will be the cough, and then it is followed by we can say wheezing and dyspnea. While in the signs, so classically if we look at the 3 signs that we will do in cases of 4 signs indeed. In cases of any respiratory disease, we do inspection, we do palpation, percussion, auscultation. So remember only one point in each science which are frequently asked in the question, the combination of these signs. Inspection, the most important thing is the mediastinal shift. Remember, in cases of asthma, it is a bilateral disease, so there will be no mediastinal shift. Mediastinal shift is absent. In palpation, we do vocal fremitus. And remember, vocal fremitus is increased by consolidation, a solid tissue in the lungs, and it is decreased by effusion or air trapping inside the lungs. So, in cases of asthma, there is a air trapping inside the lungs. So, vocal fremitus is classically decreased. Percussion. Hyperresonance will be seen in asthma because of increased air trapping. Hyperresonance due to increased air trapping. In the auscultation, so we'll do only the specific features of that particular disease. Auscultation will reveal here presence of rhonchi. Rhonchi will be positive. And classically, asthma does not produce crepitations because it is usually not associated with infections. So these are the classical signs in cases of asthma. But sometimes the signs are asked for signs of acute severe asthma. Remember, nowadays the term which was used earlier, status asthmaticus, has been replaced with acute severe asthma. So both are the same thing, but nowadays we prefer this acute severe asthma. So the signs are unable to complete a full sentence. Then use of accessory muscles of respiration. Then when we'll do the physical signs of cardiac signs, pulse will be more than 120 and there will be presence of pulsus paradoxus positive. And this is a highly important sign, pulsus paradoxus, though it is seen in cardiac tamponade also, but in respiratory condition it indicates a severe exacerbation of asthma, or we can say severe exacerbation of COPD also. So useful sign of acute severe asthma. Now in the lungs, what we'll see, we will see if there is a silent chest. Silent chest means कि breath sound absent bilaterally. Breath sounds are absent bilaterally. So these are the signs of acute severe asthma. Now coming to the investigations. So the investigation consists of basic chest X-ray, and remember, the chest X-ray of a patient of asthma is in most of the cases is normal, and a few cases, rare cases can have signs of hyperinflation also. But being hyperinflation, we can say this is a rare finding, not a common finding in cases of asthma. Now secondly, when we will do the pulmonary function test, in cases of asthma, and this section we have already done, pulmonary function test of asthma, it will show obstructive pattern, and that obstructive pattern is reversible. So what is the definition of a reversible pattern? Reversible pattern is that there is increase in FEV1 by more than 15% after beta agonist inhalation. After beta agonist inhalation. So that is the criteria for reversibility. Criteria for reversibility. Then third, when we will do the arterial blood gas analysis, and this is important, they usually ask ki what is the pattern in acid base disturbance, which acid base disturbance will be seen. So remember, when in cases of asthma, in we can say mild to moderate case, what happens that this is the airway. Usually in asthma, pathology wise, in pathology you must have studied ki almost whole length of the airway is affected by asthma, but the symptom or acute attack is mainly by constriction of the small airways. Constriction of the small airways. So when there is a constriction of small airways, oxygen entry into the alveoli is we can say less. So there is a sort of alveolar hypoxia. So oxygen is not able to enter into the alveoli. So this hypoxia stimulate respiratory centers. This stimulate respiratory centers. And when respiratory centers are stimulated, there is hyperventilation. And hyperventilation is mainly determining the CO2 concentration. So whenever there is a hyperventilation, there is CO2 washout. So PaCO2 decreases. PaCO2 decreases in cases. So this decrease in PaCO2 due to hyperventilation, we call it as a respiratory alkalosis. It is known as respiratory alkalosis. But if so, this is the typical finding in cases of a case of asthma. But when we do not treat the patient is continuously having hyperventilation all the time, and we are not treating the patient, or there is a delay in treatment, what will happens? So this hyperventilation one way it is causing respiratory alkalosis, but also simultaneously it can cause respiratory muscle fatigue. Respiratory muscle fatigue. And this respiratory muscle fatigue will lead to a decreased ventilation, that means hypoventilation. Because respiratory muscles are needed for the ventilatory process, and this ultimately will lead to PaCO2 increase. And this will call it as respiratory acidosis, or we can say this as a type 2 respiratory failure. Type 2 respiratory failure. So remember, initially in asthma there is type 1 respiratory failure, and later on it develops into type 2, especially if it is severe and not treated. And now coming to the fourth investigation that we can do, sometime during attack the PFT will be abnormal, but in between the attack PFT can be normal in cases of asthma. So what we can do a provocative test. So provocative test done are methacholine, or we can also use histamine, but histamine is slightly having more side effect. So methacholine challenge test. methacholine challenge test. So we give methacholine agent, and methacholine has a property of cholinergic, so if we give methacholine and there is a decrease in FeV1 by more than 20%, that means the test is positive. That means the airways are sensitive to the effect of cholinergic. So this is methacholine provocative test or a challenge test, and there is a decrease of FeV1 by more than 20%. Also we can do the exhaled nitric oxide test. Exhaled nitric oxide test means ki patient this nitric oxide is involved in the inflammation of asthma. So if there is some active inflammation inside the airway, it will be exhaled out. And this suggests that there is a inflammation which is present, active inflammation which is present. So this is a breath test, exhaled nitric oxide in the breath. Now coming to the treatment. So diagnosis is made. Treatment. So treatment we can divide into two groups. One group will be the treatment of acute exacerbation. Of asthma. So we start first with the oxygen inhalation, true, because these patients are hypoxic, so they will need oxygen therapy. And also simultaneously we start with the short acting beta agonist, and they are given as nebulization. Best is nebulization, because nebulization has more pressure, so patient has not to take more efforts. Then if patient is still not responding with these two therapies, then we can go to the third step, and that is we can give anticholinergic agent, and that will be ipratropium, again through nebulization. And we can also give steroids. Here steroid can be given through nebulization or can be given through IV. Remember, steroid should not be given in the beginning itself. If patient is not responding to these agents, then we give steroid therapy. Now most of the patient usually recover with these agents. So if patient is not recovering to these agents, that means ki we can call that patient as a case of acute severe asthma. So if patient is not responding to these four therapies, so by convention we can say that patient is having acute severe asthma. So question is asked, the management of acute severe asthma or status asthmaticus. So here these treatment will be given also as well as we will give IV aminophylline. And if patient is still not responding, then we go to the number 6 therapy, and that is magnesium sulfate. Remember, magnesium sulfate has got both, can be given both IV as well as nebulization. and the action is, it is a smooth muscle relaxant. It is a smooth muscle relaxant, magnesium sulfate. Now, if patient still not responding, then we go for mechanical ventilation. And still, if there is no response, then we go for general anesthesia. And the agent which is helpful in general anesthesia in cases of asthma is halothane. A slight reduction in the we can say contraction of the muscle, so it is a muscle relaxant, a sort of muscle relaxant. So this is the sequence of a treatment of a case of bronchial asthma. Now, second group of patient, these were the patients who are coming in acute exacerbation. So this is the treatment of acute exacerbation. Now, for a maintenance phase of asthma, maintenance phase of asthma. So here what we'll do, we divide the patient into different gradings of asthma, and the treatment will be different. So this grading is done on the basis of symptoms of asthma, FEV1, and the grade of asthma. Finally, the treatment in that grading. So, if symptoms are very less frequently coming, so less than once or maintenance phase symptoms are less than once or twice per week, and FEV1 is more than 80%. Is more than 80%. This grade, remember, FEV1 more than 80% is a normal finding. Last time we have discussed. So this is a case of mild asthma, and symptoms are very infrequently, so it is a mild intermittent asthma. Mild intermittent asthma. So the treatment in this condition is given as SOS, as and when required, beta agonist, and these beta agonists should be short acting, and that in inhaler form, in the inhaler form. So this is mild intermittent, only SOS beta agonists are given. Then if the symptoms are more than twice a week, but less than daily, here FEV1 is more than 80%, and this grade is known as mild persistent, Then in this grade, the treatment consists of SOS same thing that we were giving earlier, short acting beta agonist plus. Here we give low dose of inhaled corticosteroids. Low dose of inhaled corticosteroids. Then, if the symptoms are daily, like Monday morning or Tuesday evening, FEV1 here is definitely reduced 60 to 80%, and this will be classified as a moderate persistent asthma. And the treatment here consists of giving short acting beta agonist plus low dose of inhaled corticosteroids plus here we add a third agent, and that third agent is long acting beta agonist and inhaled form like salmeterol or formoterol are the agents given here. So triple combination is given, and remember short acting beta agonist will always be on SOS basis. Now further grading, further severity, if the symptoms are we can say frequent, like twice a day they are coming, symptoms become frequent and FEV1 becomes less than 60%. Remember, less than 60% is grading wise severe asthma, and it is a severe persistent asthma. And the treatment here that we give is short acting inhaled beta agonist SOS. So SOS, short acting beta agonist plus here we will increase the dose of steroids, inhaled steroid. So here it become high dose inhaled corticosteroids plus long acting beta agonist will continue in inhaler form. So the only difference in moderate to severe is the dose of steroid, of inhaled steroid is increased in this stage, and when the symptoms are very frequent, so the very frequent means they are coming say every 3 hours, every 4 hours in a day. This we call it as very severe persistent asthma. And here the treatment is all these treatment, and this we add, means all the three agents will be given in this stage: short acting beta agonist, high dose of inhaled corticosteroids, and long acting beta agonist. Along with that we add oral agents. Oral agents can be in the form of oral steroids or oral bronchodilators So these are the agents that are given in cases of very severe persistent bronchial asthma. So oral agent have a role in this stage, not in the previous stages. Now some miscellaneous drugs that are given, we can give omalizumab. This is a antibody against IgE, and the role is it decreases the frequency of exacerbations. Frequency of exacerbations. Then we can try methotrexate. Methotrexate is an immune modulator, so it is given in we can say a very refractory asthmas. Refractory asthmas. While the role of mast cell stabilizers, that is cromolyn sodium, they are in exercise induced asthma. They are mast cell stabilizers, so they are given as a preventive. They are given as a preventive. So mast cell stabilizers role is preventive, not and never in acute cases, not in acute cases. Now before finishing asthma, let's see some different types of name of the asthma, different types of name of the asthma. So different names, miscellaneous topics of asthma. So if asthma is we can say steroid resistant asthma. So the definition: steroid resistant asthma is present when there is no improvement in FEV1, no improvement with 40 milligram of prednisolone for more than 2 weeks of use. For more than 2 weeks of use. This will be called as steroid resistant asthma. Then nocturnal asthma. It is a decrease of FEV1 by more than 15% during night time, and the clinical example of this condition is tropical pulmonary eosinophilia, because the pathology is maximum during the night time in this condition, so it will be a nocturnal asthma. Then gastric asthma. Gastric asthma is we can say it is due to GERD, gastroesophageal reflux disorder, and this acidic reflux then triggers the asthma. So this asthma is triggered by acid reflux, gastric asthma. Cardiac asthma. And this is due to left ventricular failure, or we can say due to increased in left atrial pressures. So left ventricular failure or increase in left atrial pressure that causes the congestion of bronchial wall due to back pressure changes, due to hydrostatic pressure increase. So congestion of bronchial wall. So this leads to a decreased lumen. Decreased lumen. So the patient will have symptoms of asthma like wheezing will be there. Wheezing will be there. But the main reason here is from the LVF or increased left atrial pressure. And this cardiac asthma, remember, respond to diuretic therapy, while normal asthma does not respond to diuretic therapy. So treatment is mainly diuretics. So that respond cardiac asthma respond very well to the diuretic therapy. Then thunderbolt asthma. Thunderbolt asthma. This is due to breakdown of pollen grain by thunderstorms, by thunderstorm. So this is due to breakdown of pollen grain by thunderstorms. And remember, intact pollen grain is not allergen to the asthma. Intact pollen grain is allergic. It causes allergic rhinitis, not asthma. So to cause asthma, this particle is broken down by thunderstorm, and these smaller particles now they trigger the allergic reaction and trigger the asthma. So it is the broken pollen particles, breakdown of pollen grain by thunderstorm. Then we can say exercise induced asthma. Induced asthma. And this is due to mast cell degranulation by hyperventilation, and hyperventilation is by exercise. By exercise. So mast cell degranulation by hyperventilation. So let's see that treatment will depend on this mechanism of exercise induced asthma. This is say bronchial airway, and patient there is hyperventilation, there is increased rate and depth of the breathing. So what hyperventilation do? Because of exercise there will be evaporation of increased evaporation of bronchial secretions. So here the fluid will get evaporated, and this typically occur when there is a say a dry air or dry weather. So remember, dry weather increases the rate of evaporation. So what happens, this fluid water is being evaporated out from here. So this lining or this here the bronchial secretions, these secretions they become hyper osmotic. So electrolytes remain there, but the water is being evaporated out. So this part of lumen become hyper osmotic. So mast cells are inside. So these are the mast cells. Because of increase osmotic substance here, so this signals mast cells to release their content. So the stimulus to mast cells to release their contents is the hyperosmotic fluid of the bronchial airways. So mast cell become degranulated, and we all know that mast cell, one of the molecule released is histamine. So remember 2 or 3 important points, because usually mistakes are made in this. First is this exercise induced asthma, it occur after exercise, not during exercise, not during exercise, because this process of evaporation and the degranulation takes time. So this is after exercise, and in most of the cases it is self limiting within 30 minutes, within 30 minutes. But if patient is not responding, so the treatment here is consisted of, suppose, so what oxygen we will do, we will prevent this evaporation process. So how we can prevent the evaporation of water from the bronchial secretions? By giving humidified oxygen, so the water evaporation will be decreased. So humidified oxygen. And because of the effect of histamine, there is bronchoconstriction. We can use here beta agonist inhalers. Yes, true. Inhalers can be given. And we can also give inhaled corticosteroids also. Inhaled corticosteroids also as a treatment of exercise induced asthma. And remember, those agents like sodium cromolyn, which are mast cell stabilizers, they are given as not in the treatment but for prophylaxis or for prevention. But once the episode has occurred, there will be no role of these agents. So this is the second mistake which is usually done, So treatment does not include sodium cromolyn, it is just for prevention, So this was the asthma topic. Now coming to the second airway disease, and that is COPD. COPD. Now, okay, brittle asthma, let's see. Brittle asthma is by definition sudden deterioration of asthma. Sudden deterioration of asthma. It is of two types, type 1. In type 1, this we will better understand with the graph. So these are the symptoms. And this is the duration. So in type 1, the patient symptoms means ki below is the asymptomatic phase, and this is the symptoms, severity of the symptoms. So in cases of type 1 brittle asthma, patient is baseline symptoms are present. Baseline maybe mild or to moderate symptom will be present, and suddenly there is a deterioration in the symptoms like this. Patient become highly symptomatic, from mild to moderate, highly symptomatic, and this cause or mechanism is due to query superimposed infection, which has caused acute deterioration, and treatment here is consisting of steroids plus infusion of beta agonist. And query, there is a query possibility of infection, then we can add antibiotics. So type 1 means ki patient is baseline symptomatic, and then there is a sudden deterioration. While in type 2, what happens? These are the symptoms. Patient is asymptomatic like this, and suddenly there are unpredictable episode, unpredictable deterioration. So type 2 is unpredictable. Before that, patient was absolutely without any symptoms, and then sudden deterioration. Mechanism here is a type of anaphylaxis which has occurred. A type of anaphylaxis which has occurred, and the treatment here, the patient usually does not respond to beta agonist or may not be even to steroids. So here we have to give epinephrine. We have to give epinephrine. So this is a very important part of brittle asthma that has to be recognized, because epinephrine can be life saving in this type of brittle asthma. Now coming to the COPD. So in COPD, we can say कि it is mainly of two types. One is chronic bronchitis. The epidemiological definition of chronic bronchitis is sputum production for more than equal to 3 months per year for more than 2 consecutive years. For 2 consecutive years. But remember, chronic bronchitis is not labeled as COPD unless there is bronchial obstruction. So if this definition is present, sputum production for more than 3 years, for more than 2 consecutive years, but without any obstruction of the airway, then it is not COPD. It is not COPD. So chronic bronchitis, to be labeled as COPD, obstruction is required. Obstruction is required. Now emphysema. Emphysema is predominantly a disease of parenchyma, and along with parenchymal destruction, there is a destruction of small airways also. So emphysema is parenchymal destruction, and this is the elastic parenchyma which is destroyed with destruction of airways, destruction of airways distal to terminal bronchiole, distal to terminal bronchiole. And rest you should know about the pathologies of this type of emphysema, ki what are the types of emphysema, and that will be the topic in details you should read from the pathology chapter of your Robbins, from the pathology of your Robbins. So we will do only the clinical and important medicine features of these two types of diseases. Now coming to the risk factors. And risk factors, most common risk factor is smoking. And remember, 90% of COPD are smokers. But 10% of smokers develop COPD. So this is a paradox. This is a paradox. Ki only 10% of smoking smokers, they develop this disease, while if there is a COPD present, then 90% patient will give history of smoking. Will give history of smoking. Will give history of smoking. Now, other risk factors can be there. and these risk factors are genetic, and suspect genetic risk factors in three situations: uh, young age less than 50 years, then family history positive of COPD, and patient is non-smoker. So these are the categories in which we will should suspect genetic factor, and the most common genetic factor implicated in emphysema is alpha 1 antitrypsin deficiency. Alpha 1 antitrypsin deficiency. So in any of these group and patient is coming as COPD, always do alpha 1 antitrypsin levels, because if it is because of alpha 1 antitrypsin levels, supplement of alpha antitrypsin will stop this type of disease, and this causes usually pan-acinar emphysema. So this type of emphysema will stop after giving alpha antitrypsin, Now is the occupational risk factors also associated, and these are the gold and coal mining associated with COPD, while in the air pollution, the most common air pollution implicated is sulfur dioxide. Then if we talk about some infections, infection implicated for developing say bronchitis, they are influenza, parainfluenza, and coronavirus. So these are implicated for the risk of COPD. Then coming to the clinical features. Symptom wise, most common symptom is cough with sputum, which can be less in cases of emphysema, but it is highly characteristic of chronic bronchitis. Then dyspnea, while wheezing is mainly seen in cases of acute exacerbations. It is not otherwise, but it is mainly a symptom of acute exacerbation. So most common being cough with sputum. Now the signs. So the signs of COPD, again in the same sequence: inspection, where most important is mediastinal shift. So it is a bilateral disease, so there is no mediastinal shift of COPD. Palpation, the most important sign that we'll do is vocal fremitus. And because there is more air which is trapped, so vocal fremitus in more air is decreased. Percussion. Percussion, because there is more air inside the lungs, there will be hyper resonance. Auscultation, it will characteristically reveal rhonchi as well as crepitations will be positive here, even without infection. So remember, creps are positive in COPD while they are absent in asthma. Now coming to the investigations. And remember one more term in clinical features. Earlier the terms used for bronchitis was blue bloaters, and for emphysema pink puffers. but remember, nowadays, according to gold, we can say guidelines. Gold guidelines are for COPD, obstructive disease patients. So these terms should be not used. So they are now outdated terms because there is a overlap. Like emphysema people can have cyanosis, so they can be blue, while chronic bronchitis they have polycythemia, they can be pink. So this term should be avoided. Nowadays it has been outdated, this term. Now coming to the investigations, first is the chest x-ray, and that will invariably shows signs of hyperinflation. Signs of hyperinflation. So let's see how does it look like. So this is the chest x-ray. There is lot of air inside the lungs, so that air will cause the heart shadow to become narrow. So this is the heart shadow. So this is called as tubular heart shadow. This is because of increased air, which is increasing the volume of the lungs and making the heart shadow smaller on the chest x-ray, on the chest x-ray. While this air will also compress the diaphragm, will compress the diaphragm. Normally diaphragm is convex upwards, but because of this air, the diaphragm become flat. So this is called as flat diaphragm. Flat diaphragm. Now normally this is sixth rib, this is sixth rib. So if patient inflate, take a deep inspiration, in normal conditions the diaphragmatic origin maximum it can go at the level of sixth rib, not beyond sixth rib. But if the diaphragm is going below the sixth rib, we can say origin below sixth rib. It is again a sign of origin of diaphragm. Origin of diaphragm. Below the sixth rib, it is a sign of hyperinflation. Hyperinflation. Now coming to the pulmonary function tests. So pulmonary function test will reveal irreversible obstructive pattern. And irreversible obstructive pattern is increase of FEV1 by less than 12% after beta agonist inhalation. So this is irreversible obstruction. Increase less than 12% of beta agonist. So this clear cut differentiated from a case of asthma. Now coming to the arterial blood gas analysis. So this will classically shows a case of a chronic respiratory acidosis. So typically it is a case of hypoventilation, and that hypoventilation is present for many months to years. So it is a chronic respiratory acidosis. Then for suspected, we can say alpha antitrypsin deficiency, so serum alpha 1 antitrypsin levels. And HRCT chest, it is specially to make a diagnosis of emphysema. To make a diagnosis of emphysema. Chronic bronchitis is mainly a diagnosis of clinical features plus tests like pulmonary function test. But HRCT can easily make the diagnosis of emphysema. Now, diagnosis is made, coming to the treatment. But before treatment, let's do the staging of COPD. So, staging of COPD is done on the basis of FEV1 and the ratio of FEV1 upon FVC. FVC. So prominent bronchial vessels on X-ray, represent that there is a sort of we can say complication of COPD. That means there is a prominent dilated blood vessels of the pulmonary system, prominent dilated. So prominent bronchial vessel will not diagnose COPD. And remember, this is a we can say generalized in diagnosis given by the radiologist, like prominent bronchovascular markings. So vascular marking as such will not make, or they are not pathognomic of COPD, not pathognomic of COPD. Now, the stages. Stage 0. Here FEV1 is more than 80%, which is normal. FEV1 upon FVC ratio is more than 0.7, which is also normal. And this we have already done in our previous class of respiratory system, pulmonary function test. So why this stage is 0? Because these patients are at risk of developing COPD because they are smoker. So DLCO in emphysema, this we have already done. In the pulmonary function test, that DLCO in emphysema is decreased because of decreased in the capillary density of the alveoli, because parenchyma is destroyed. Along with parenchyma, blood vessels are also destroyed. So DLCO is obviously reduced. So these patients are at risk because they are smokers. So they are classified into stage 0, stage 1. So stage 1 is this will be anterior marking, anterior margin of the sixth rib, So stage 1 FEV1 here is more than 80%, but the ratio is decreased. So that means a sensitive marker of COPD will be the ratio. That means, suppose a patient's baseline FEV1 was say 90% of the predicted. So it has come down to say 85%, but FVC is normal. So there is a baseline decrease, but FVC is normal. So the ratio is less than 0.7. But still FEV1 is more than 80%. That is grade 1. Grade 2. Now the FEV1 is reduced 50 to 80%. And ratio is less than 0.7. Third, 30 to 50%, less than 0.7. While 4, here the FEV1 is less than 30% and ratio 0.7. Ratio less than 0.7. So these are known as gold classification of COPD. GOLD is a global initiative for obstructive lung diseases. Global initiative, and this is a reputed guidelines for a case of COPD patients. For a COPD patients. Now coming to the treatment. So treatment of COPD, again we'll start with the treatment of acute exacerbation. Acute exacerbation. So any characteristic feature in HRCT in cases of emphysema, feature will be the same feature, like there will be destruction of airways distal to terminal bronchiole. There can be the fusion of the alveoli. There can be, we can say, a presence of bulla, small air spaces containing the air can also be seen. So same feature will be seen in the HRCT. Now acute exacerbation treatment start with again oxygen inhalation. Secondly, these acute exacerbation most common precipitating cause is the infection. So the mainstay of treatment in acute exacerbation is antibiotics. And the three common infection which are responsible for acute exacerbations are streptococcus pneumonia, H influenza, and Moraxella catarrhalis. Moraxella catarrhalis. So to cover these organisms, the best antibiotic will be cephalosporin. Cephalosporin. And cephalosporin that we commonly used is ceftriaxone. Now, third, because patient has two components in acute exacerbation. First will be a fixed obstruction, and second will be a obstruction by infection. So we are covering antibiotic, but simultaneously we can give here bronchodilators. So whatever little bit of reversibility we can achieve, we will achieve, and agents are same: short acting beta agonist and ipratropium. And fourth, again the essential component of treatment is these patients which are because of infection, they have some sort of inflammation also. So we have to reduce the inflammation by giving steroids. So IV steroids are given. So these are the mainstay of treatment of a acute exacerbation of COPD. And remember, in asthma we were using magnesium sulfate, but we do not give here. But if still patient is not responding to these therapies, then the option left is mechanical ventilation. And here the question comes, which mechanical ventilation we will do. The mechanical ventilation can be non-invasive or can be invasive. Invasive means we are putting endotracheal tube, and non-invasive means we are giving the mask high pressure oxygen we can give, that will be by BiPAP. Bidirectional positive airway pressure, positive airway pressure. So this mechanical ventilation, when the patient is not responding to these, is done, and we prefer usually non-invasive. We prefer usually non-invasive, because once the patient goes into invasive, the patient's efforts will be zero, and patient will be dependent on the ventilator. Will be dependent on the ventilator. So invasive, the indications are if patient is hemodynamically unstable, hemodynamically unstable, or if a patient is having altered sensorium. These are the two primary indications of giving invasive ventilation. Question came like this, ki a patient of COPD is coming in shock, unconscious. So the first step will be maintain the airways and give invasive ventilation. Invasive ventilation. So this is the acute exacerbation. Now coming to a stable COPD patient. So second will be the maintenance, or we can say a stable COPD patients. So the most important treatment, of a patient of stable COPD is smoking cessation, because 90% are smokers. And for smoking cessations, drug used are nicotine replacements. Then drug we can use is centrally acting bupropion, antidepressant agent, but can be used for smoking cessations. And again a centrally acting varenicline. Varenicline. So these are the three agents that can be used, and all of these are available in India. So these agents we can use. Now stable COPD, we can give bronchodilators. Though bronchodilators, they will not cause maximum dilatation, but little bit of reversibility, whatever we are achieving, we can achieve with bronchodilators. And the bronchodilators used are ipratropium and long acting beta agonist. Long acting beta agonist. There is no role of short acting beta agonist, because it is given in acute exacerbations of COPD. We can give oral steroids. And indications of giving oral steroid, because oral steroids do have their side effect. So oral steroids indications are when there is frequent exacerbations, and the definition of frequent exacerbation is more than equal to 2 episodes per year. That is frequent exacerbation. In that patient we can give oral steroids. But none of these treatment decreases the mortality. So the only treatment which decreases the mortality of a patient of COPD is home oxygen therapy. Home oxygen therapy. Now this patient takes oxygen cylinder at home, and then take oxygen usually at a low flow rate, and indications will be when the oxygen saturation of the patient is less than 88% at room air. So oxygen saturation less than 88% at room air, or oxygen saturation less than 90% but with signs of or complications of COPD like pulmonary hypertension. Pulmonary hypertension. So even with this saturation, we'll put the patient on home oxygen therapy. Home oxygen therapy. Now, systemic or extra pulmonary manifestations of COPD, that means the complications of COPD on the body, we can say that include the systemic complications of COPD. These include number one, core pulmonale, and core pulmonale subsequently leads to congestive hepatomegaly or congestive hepatitis, we can say. So core pulmonale right cardiac output is decreased. If right cardiac output is decreased, remember obviously left ventricular cardiac output decreases, because whatever the blood flow is coming from the right side will be the blood coming from the left side, So what this will do, this will stimulate renin is increased. If renin is increased, obviously aldosterone will increase, and if there is a increased in aldosterone, so patient will have a sodium retention. So not only core pulmonale is a cause of edema in patients of COPD, it is also the systemic elevation of aldosterone responsible for sodium retention. Fourth, there is COPD is we can say a type of chronic inflammatory condition, so TNF alpha is elevated, and that is because of chronic inflammatory process, TNF alpha. And TNF alpha, tumor necrosis factor, and this leads to the cachexia. Muscle breakdown, or we can say the muscle mass will reduce, cachexia will be there. Remember, any case of chronic elevation of TNF alpha will produce cachexia, and of course there can be side effects of medications systemically, and these include like osteoporosis because of use of steroids. So these are the systemic or extrapulmonary manifestations of COPD. Now coming to the third disease in the airway, and very importantly typical questions comes from this disease, and that is osteoporosis from the effect of prolonged steroid use, decrease in bone marrow density, T-score of more than minus 2.5, now coming to this bronchiectasis. Yes, not polycythemia, we can say erythrocytosis due to effect of hypoxia, that RBC count can increase. Due to hypoxia. So bronchiectasis, The exact definition of bronchiectasis is, a typical case of bronchiectasis is irreversible dilatation and destruction of mid size airways. Okay, different modes of ventilation. This topic is covered or will be covered in the anesthesia, the different modes of ventilation. Because today we have a very tight schedule, lots of things to be done in till 9 o'clock. So that will be done definitely in anesthesia. Okay, so irreversible dilatation and destruction of mid-size airways, and mid-size airway is defined as the fifth to ninth generation of bronchus. Okay, so it was not covered. So what we can do, because I think today we will not have time, so whenever I will be scheduled for another class, I will show you the chest x-rays, the visual aspect of the some parts of respiratory system like x-rays, pulmonary function test, and that time we can discuss with the mode of ventilation. So bronchiectasis is a dilatation and destruction of the mid-size airways. Mid-size airway means fifth to ninth generation of bronchus. This is a typical location, medium size airway, but remember there can be exceptions also. Like bronchiectasis can affect the large airway, can affect the proximal airways also. So let's see what is the mechanism. So by mechanism we will be able to identify the risk or causes of bronchiectasis. So mechanism, remember, it is a vicious cycle. It can start anywhere. So let's do ki this is the airway, and normally whatever the secretions are coming in the airway, secretion can be normal secretions, can be from the inhaled sort of antigens. They are moved out from distal to proximal direction and moved out from the tracheobronchial tree normally, these secretions. And what helps? The lumen of the airways, it is normal, it is not obstructed, and these ciliary functions, this is a very basic physiology, that cilia help in removing those antigens, those secretions out from the lungs. So what happens if there is some sort of obstruction? So first is the obstruction. Obstruction may be by some external lymph node. So this obstruct the airway. So the secretion is not able to get drained out. So some sort of obstruction. And ciliary dysfunctions. So because of these two reasons, that there is obstruction and because of ciliary dysfunction, what happens, that there will be no drainage of these secretions, and that predispose to infection. So there will be infection. And when infection is there, there will be recruitment of neutrophils. and neutrophils releases one enzyme known as elastase. So this elastase enzyme that causes the destruction of airway wall. So destruction of airway. So when there is a destruction of airway, elastic tissue of the airway is damaged. So the airway become very weak and become dilated. So destruction of airway, dilatation of the airway and destruction of the airway. Destruction means though there is a paradox that airway is dilated anatomically, but functionally airway is obstructed. Reason, anatomically wise it is dilated, but the dilated section contain lots of secretions inside it. So the effective lumen is narrowed down. So it is a type of obstructive airway disease. Obstructive airway disease. Remember, anatomically dilatation but functionally obstruction. So due to dilatation of the airway, it become destroyed because dilated leads to the loss of ciliary functions also. So destruction leading to ciliary dysfunction, and that further predisposed to infection, and then the cycle will continue. The cycle will continue in this way. So the cause can start from anywhere, any site. So the cause can start from, say, infection. Cause can start from increased elastase activity. Cause can start from the destruction of the airway. Cause can start from the obstruction. Cause can start from the ciliary dysfunction. So anywhere the cause can start, which predispose to bronchiectasis, and that will establish a vicious cycle, and that will be a progressive disease. It will be a progressive disease. So let's see one by one what are the causes or risk factors. Risks or causes. So starting with the first, let's start with the congenital one, like ciliary dysfunction, where cilia are not functioning properly. So this include Carter-Jenner syndrome. Carter-Jenner syndrome, and this is associated with sinusitis plus infertility plus there will be situs inversus. Situs inversus. So this is a classical triad, and of course bronchiectasis. Then there is a Young's syndrome, which is idiopathic obstructive azoospermia. Idiopathic obstructive azoospermia, and of course with bronchiectasis. Now second in the sequence is infection, and basically those infection which are affecting the airways, they will be responsible for destruction, and these infections which characteristically affect the airways, they are Bordetella, pertussis, then it is chlamydia, not mycoplasma, chlamydia. Viral infections like measles and mumps. and of course mycobacterium TB. Mycobacterium TB. Then increase elastase activity, and that we have seen in cases of alpha 1 antitrypsin deficiency. Alpha 1 antitrypsin deficiency, that was also causing the emphysema. Also causing the emphysema. Now fourth in that vicious cycle will be the destruction, direct destruction of the airways. Destruction of airways, and that is by the antibodies. And these antibody associated destruction is a typical feature of SLE. It can be seen in cases of allergic, bronchopulmonary, aspergillosis, ABPA, that is mainly affecting the proximal or the central airways, proximal or central airways. Then fifth is dilatation of airways, that predisposes to bronchiectasis. So this dilatation can be by traction of fibrosis. Like this is the airway, and if there is a parenchymal fibrosis, so this fibrosis will cause traction and make this airway dilated. Make this airway dilated. And this example are cystic fibrosis and radiation exposure. Radiation exposure. Then sixth is obstruction. Obstruction of the airway can be by lymph nodes from outside or can be internally by adenomas. Can be by adenomas. So they does predispose to the bronchiectasis. And remember, lymph node enlarged by tuberculosis can also by this mechanism leads to bronchiectasis. Direct tuberculosis, yes, of course, and by causing lymphadenopathy, second mechanism of tuberculosis. Then seventh will be that there is a decreased clearance of secretions without obstruction. Decreased clearance. So there is no ciliary dysfunction, there is no obstruction, but still there is a decreased clearance of secretion, and that is typically seen in a syndrome known as yellow nail syndrome. That is yellow nail syndrome. Yellow nail syndrome is a congenital disorder in which there is a lymphatic hypoplasia. Lymphatic hypoplasia. That means कि lymphatic are not able to drain the secretion out. So the airway, this is the airway. The normal secretions are drained by lymphatics. They are drained by lymphatics. So if there is a lymphatic hypoplasia, secretions will not be drained out, and then they predispose to bronchiectasis. Also in this lymphatic hypoplasia, what happens? The drainage from pleural fluid. This is pleural fluid, and the normal drainage will not take place because of lymphatic hypoplasia. So there is pleural effusion. From limbs, it will not be drained out the lymphatics, so lymph edema will be there, and there will be decreased drainage from the nail bed. So nails become yellow, yellow nails. So this is a four classical features: bronchiectasis, pleural effusion, lymphedema, yellow nails, that constitute this typical syndrome, yellow nail syndrome. Yellow nail syndrome. Now coming to the clinical features. So clinical features, symptom, most common symptom is sputum. Characteristic features, foul smelling and large volume of sputum. Then there is one more characteristic symptom which is we can say not seen in COPD or asthma, and that will be hemoptysis. That will be hemoptysis. And the source of hemoptysis, usually asked, is hypertrophied bronchial artery, which is supplying that portion of dilated airway. So source of bleeding is from the bronchial artery, which is hypertrophied due to dilated segment of the airway. Most common cause of bronchiectasis is bronchopneumonia. That means infection which are affecting the airways. Now coming to the signs. So the characteristic clinical feature which will be mentioned in the general physical is clubbing. So without clubbing, suspect a diagnosis of bronchiectasis. So inspection, what we'll see, there will be mediastinal shift absent. In palpation, remember this is obstructive airway disease, so there is a retention of air inside, so vocal fremitus is reduced. While on percussion, because of air retention, there is hyper resonance. And in auscultation, there will be typical feature of crepitations, because the most common airway affected is the medium size airway, so the creps are classically mid inspiratory, and of course there is a lumen obstruction, rhonchi will be present. But remember, most important will be clubbing to make and differentiate it from COPD. Now the chest X-ray investigations. First is chest X-ray, and chest X-ray will show dilated airways. And how does dilated airway look like? Suppose this is a chest X-ray. This is the trachea, bronchus. So if we'll see a cross section of the airways, this will look like this. Medium size airway will be dilated, and this is known as ring shadow. And when we'll see the dilated airway in a horizontal plane like this, horizontal dilated airways, which normally are not visible because they are not dilated normally. So this is known as tram track appearance. And when characteristically there is a dextrocardia which is present, that will suggest that it is a case of Carter-Jenner syndrome. And when pleural effusion is also seen along with bronchiectasis, it is a case of yellow nail syndrome. So these are the findings that we can expect in a case of chest X-ray in bronchiectasis. But there will be exceptions, like instead of mid-size airways, proximal airway can be affected. So causes of proximal, or we can say a central bronchiectasis. And three conditions will produce these proximal involvement of the airways. First will be ABPA, allergic bronchopulmonary aspergillosis. Second condition will be, second and third will be congenital conditions, and they will be like weakness of the wall of trachea and bronchus congenitally. That means developmental defect of the wall of trachea and bronchus, tracheo bronchomegaly, and that syndrome is known as Monier-Cohen syndrome. Monier-Cohen syndrome. While there can be again second syndrome in which bronchus is affected mainly instead of trachea, so that is called as bronchomalacia, and this syndrome is known as William Campbell syndrome. William Campbell syndrome. Now there can be other exceptions, like remember bronchiectasis is a bilateral diffuse uniform disease. ABPA is allergic bronchopulmonary aspergillosis, that we have just discussed, antibody destruction, allergic bronchopulmonary aspergillosis. So usually bronchiectasis is bilateral diffuse, but if specific zones are affected, like caution is upper lobe bronchiectasis. So this is a characteristic of cystic fibrosis, and due to radiation, if it was done for the neck tumors, so during the radiation of neck, the upper zone is simultaneously affected. If it is a mid zone or mid lobe in the bronchiectasis, it is usually the ciliary dysfunctions. While if and also mycobacterium, which is Mycobacterium avium complex. Mycobacterium avium complex, lower lobes, and it is because of recurrent ABPA involves upper lobe, that can be pulmonary infiltration. ABPA affect the proximal airway. So we are talking about bronchiectasis, not the infiltration. So bronchiectasis will be of the, say, trachea or the bronchus. So this is a central bronchiectasis. Yes, it do affect pulmonary parenchyma also, but that will be infiltrations. So lower lobe is recurrent aspiration. Recurrent aspiration will cause lower lobe bronchiectasis. Now coming to the other investigations, the investigation of choice for bronchiectasis is HRCT. HRCT chest. That will clear cut distinguish that it is a case of bronchiectasis. While in other test, if we'll do a pulmonary function test, that will characteristically shows a chronic, we can say, or instead of chronic, irreversible obstructive pattern. Irreversible obstructive pattern. And in arterial blood gas analysis, It will be a case of chronic respiratory acidosis. Chronic respiratory acidosis. Now coming to diagnosis is made, treatment. So treatment usually consists of say in a acute exacerbation phase. Again here the exacerbations are mostly by the bacteria. So we give antibiotics. And the most common bacteria, again MCQ, is Pseudomonas. Therefore, the antibiotic that we have to give is either ceftazidime or we give piperacillin, tazobactam combination or tazobactam combinations, antibiotic. Then the next treatment is usually same as that of COPD, like we give here bronchodilators. Though there is a irreversible obstruction, but because of the infection, the obstruction increases. And we can here also give IV steroids to reduce the inflammation. And supportive therapy like mucolytics. And in mucolytics, we can add, say, like N-acetylcysteine and bromoxine. Then last but not least, it is the chest physiotherapy to drain out the secretions. Then for a stable patient of bronchiectasis, the treatment usually is given as long-acting beta agonist inhalers. And treatment of underlying disorder, like we can give steroids if it was because of allergic bronchopulmonary aspergillosis or it was because of SLE, antibody induced. So in that case, underlying disorder, steroid we can use in those conditions. And while of course the continuous process of chest drainage, that is chest physiotherapy, is must. Chest physiotherapy. Now in bronchiectasis, one part of MCQ is also asked about the complications of bronchiectasis. So bronchiectasis of course is a cause of respiratory failure, that is a pulmonary manifestation. Then bronchiectasis do lead to cor pulmonale. It leads to hypoproteinemia. Reason being that there is a protein loss in sputum. There is a protein loss in the sputum because of excessive sputum production. So then there can be metastatic abscess, means from lungs that infection can go to spleen, to the heart valves causing endocarditis, to brain causing brain abscess. So metastatic abscess. It can also cause secondary amyloidosis. Secondary amyloidosis, subsequently leading to nephrotic syndrome. Nephrotic syndrome. and rarely but possible again in the lungs, it can cause rupture the hypertrophied segment of airways that can extend and rupture the pleura. So pneumothorax can occur. Pneumothorax can occur. Also remember, which is not a complication. So remember, bronchiectasis does not predispose to carcinoma. So carcinoma of lungs is not a complication of bronchiectasis, not a complication of bronchiectasis. So with this, we finishes the airway diseases of the lungs. Now, the topics left are the carcinoma of the lungs, the pneumonias, pulmonary vascular disease, and pleural disease. So, rightly we can take 5 to 10 minutes of a break, and then we'll resume with the carcinoma of the lungs. Okay, so starting with the carcinoma of the lungs and risk factor or causes of carcinoma of the lungs. First is does bronchitis lead to CA bronchus? That we have already discussed. It does not cause CA bronchus. Dutch hypothesis. Dutch hypothesis was the hypothesis of overlapping features of asthma, emphysema, and chronic bronchitis. This is Dutch hypothesis. Dutch hypothesis means some patients group will be there which have both the feature of emphysema and bronchitis, asthma or bronchitis, asthma or emphysema. So overlap features in a single patient is called as Dutch hypothesis. Now coming back to the CA lung, most common cause we all know is the smoking. But other risk factor, if we'll go question wise, what is the most common gas that leads to carcinoma of the lungs? Answer is radon. And radon is, we all know, is produced from the radium. Produced from the radium. And radium we all know is a degraded product of aluminium. So the patients who are working in aluminium mines will have a increased risk of carcinoma of the lungs. Then most common nutritional cause. Vitamin A deficiency. Maybe because of lack of antioxidant effect that there is an increased predisposition to carcinoma. So that is a hypothesis, but it has proven that vitamin A deficiency is associated with CA lung. Then most common pneumoconiosis. Occupational lung disease. Answer is asbestosis. Asbestosis. Then most common metal that predisposed to CA lung is arsenic. is arsenic. And most common air pollution, sulfur dioxide, particulate sulfur dioxide, air pollution. There are other risk factors also besides these most common in individual categories. They include uh, metals like nickel, chromium, then silicosis. Silicosis, last time we discussed, it is a probable carcinogen. Probable carcinogen. Then there is a condition known as scar carcinoma. Scar carcinoma means that it arises in the fibrosis segment of the lungs, predisposed to scar carcinoma, and this fibrosis induced carcinoma. Question are also asked which is the most common type, and most common type of fibrosis induced is adenocarcinoma. Adenocarcinoma. And yes, we have just started the carcinoma of the lungs. So it can be by tuberculosis. So tuberculosis indirectly is a risk factor for carcinoma of the lungs if it is causing fibrosis. If it is causing fibrosis. Then what are the pathological types? So there are four main pathological types of CA lung. Squamous cell, small cell, adenocarcinoma, and large cell. So to differentiate these, or we can say we'll make a sort of a table that what is the site of these carcinoma, where does they originate from mainly, whether they originate from the proximal part, that is the central part, or they are peripheral part like alveoli. So squamous cell and small cell, the site of origin is central. While adenocarcinoma and large cell, they are peripheral. Then what is the pathological lesion? Remember, those which are central, they cause blockage of the airway, leads to collapse of the distal segment of the lungs. So those which are causing central, they will lead to collapse of the lungs, distal to that obstruction we can say, while peripherals they usually start with pleural effusion. Also, there is a property of squamous cell that it causes necrosis of the local lung tissue. So necrosis means it is causing cavity. So cavity causing carcinoma is squamous cell carcinoma, while it is also property of large also causes cavity, but most common cause will be squamous cell. Then adenocarcinoma, yes, there is a subtype of adenocarcinoma which is the bronchoalveolar carcinoma that leads to consolidation. Now coming to the epidemiological significance of these types of carcinoma, means most common, maximum. So out of this, if question come which is the most common in world, so remember adenocarcinoma is most common carcinoma worldwide. Adenocarcinoma. But if question come, which is the most common in India? Most common in India is squamous cell. Is squamous cell. And if question comes, कि which is most strongly associated with smoking, answer is squamous cell. So most strongly associated with smoking is squamous cell. Which is most commonly associated with asbestosis. So this is most common carcinoma seen in asbestosis, adenocarcinoma. This is the most common carcinoma which is seen in female. Most common carcinoma seen in non-smokers. Most common carcinoma seen in young age. Seen in young age, that is less than 50 years of age. Carcinoma with maximum metastasis is small. Carcinoma with maximum metastasis is also small. Maximum paraneoplastic. Paraneoplastic. Most common carcinoma associated with hypercalcemia of CA lung is squamous cell. So most common associated with hypercalcemia. Then best prognosis of CA lung. Best prognosis of CA lung. It is a subtype of adenocarcinoma which is bronchoalveolar carcinoma. Remember, it is a subtype of adenocarcinoma. This has got a best prognosis. Best prognosis. And worst prognosis, of course, is small cell carcinoma. Now coming to the clinical features. So the clinical features, symptom wise, if question come, most common symptom of CA lung, it is cough. Can be a new onset of cough or a worsening of pre-existing cough. New onset or worsening of a cough. And other features are hemoptysis, and hoarseness of voice. These are because of the tumor effect. Now the signs will be dependent on which pathology of CA lung is there, which is causing these changes. So if we look at the signs, and this combinations will give you the diagnosis. So first is the inspection, palpation, percussion, auscultation, and the diagnosis. Which pathology is this? Whether it is a collapse, pleural effusion, consolidation. So inspection, mediastinal shift is away from the lesion. So that lesion is pushing the mediastinum away. And when we'll do the palpation, in palpation we'll see vocal fremitus. So if vocal fremitus is low in two conditions, either air or in cases of fluid. Percussion is stony dull, and auscultation reveal breath sounds are decreased. So this is suggestive of diagnosis pleural effusion. Then if inspection shows that mediastinum is towards the lesion, mediastinum is shifted towards the lesion, and when we will do the vocal fremitus, it is decreased, percussion is dull, and breath sounds are decreased. So this is a typical case of a complete collapse. The segment is completely collapsed, the blockage is complete, so it is causing this sort of manifestation, While similar lesion, mediastinum is towards the lesion, but vocal fremitus is increased along with dullness, and bronchial breath sounds positive. Remember, bronchial breath sound positive with vocal fremitus high, but mediastinum is shifted towards the lesion. This is not consolidation, because remember, in consolidation there is no mediastinal shift, but here there is a mediastinal shift. So this is a case of incomplete collapse. Incomplete collapse. That incomplete means the collapsed segment is near to the chest wall. Now, in cases of cavity, let's say, what will be the findings? Inspection, palpation, percussion, and auscultation. Diagnosis is of a cavity. So inspection will be mediastinum. There is no shift. Palpation, that is vocal fremitus. Local area, vocal fremitus will be increased because this cavity is near to the chest wall. So whatever the vibration coming from the larynx, we can easily palpate in the chest wall. Percussion will show because that cavity contain air, so percussion will be decreased. That means ki here the no, it is air is there, so it will show hyper resonance, not decreased, hyper resonance. That will be focal. And if cavity contain fluid, then that focal hyper resonance will convert into dullness. So if air is there in the cavity, hyper resonance. If there is a fluid in the cavity, there will be dullness. Auscultation, cavity also produce bronchial breath sound. Now coming to the clinical feature again. So clinical feature can also be because of these clinical feature was because of the direct tumor effect. Clinical feature can be because of local invasion. So local invasion, first and foremost important is the Pancoast tumor. It is also known as superior sulcus tumor. That means this is the lung, this is the apical part. So this tumor location is posterior to the apex. Here is the tumor, posterior to the apex, and here is the spinal segments posteriorly of C8 and T1 root values. So nerves are going from here to supply the upper limb, to supply the upper limb. So if this tumor is posterior to the apex, this will definitely compress these nerves, and T8 and C8 and T1, it participate in the formation of, we all know, median or ulnar nerve. Which nerve? It is a ulnar nerve. So there will be pain or paresthesia in the distribution of ulnar nerve. That is the medial aspect of the hand. And also, especially C8, it supply intrinsic muscles of the hands. So it leads to hand muscles atrophy. Hand muscle atrophy. Also, from C8 and T1, there is upward ascent of cervical sympathetic chain. Upward ascent of cervical sympathetic chain. So that will be affected, and that leads to Horner's syndrome. Horner's syndrome. So these are the manifestation of Pancoast tumor. And remember, Pancoast tumor is not histological diagnosis; it is anatomical diagnosis. The location of the tumor defines Pancoast tumor. So the question comes: which is the most common type of carcinoma leading to Pancoast tumor? So most common type leading to Pancoast tumor is squamous cell. Now coming to the second local invasion is superior vena cava obstruction. Superior vena cava obstruction. So basically here the fundamental is superior vena cava is obstructed by not tumor directly, it is obstructed by superior mediastinal lymph nodes, which are enlarged, yes, of course, because of the tumor, because of the carcinoma. But carcinoma directly does not obstruct superior vena cava. And the values here are 10% of all small cell, they cause SVC obstruction, while 5% of all squamous cell, they cause SVC obstruction. So question is, most common type of CA lung causing SVC obstruction. So answer will be small cell. It predisposed to maximum to SVC obstruction. Now coming to the other manifestations, that is extrathoracic, and extrathoracic include first metastatic manifestations. So we have done the direct tumor effect, that is collapse consolidation, then local invasion, Pancoast tumor, SVC obstruction, then metastatic manifestations of CA lung. So the manifestation will depend on the site of metastasis and the manifestation. So brain manifestation is stroke. Liver, the manifestation is abdominal pain. Remember, jaundice as metastasis by CA lung is a rare manifestation. Rare manifestation. So main will be abdominal pain. Adrenal. usually asymptomatic, while bones, it cause bone pain characteristically. So let's see which is the most common site where metastasis goes. So we'll do the percentages, and from percentages it will be clear. Of all the cases of CA lung, brain has 50%, liver 30%, adrenal 30%, and bone less than equal to 10%. Less than equal to 10%. So if question comes which is the most common site of metastasis from CA lung, answer will be brain. 50% of all CA lung metastasize to brain, isolated, or we can say combination or combination. So we are talking about CA lung, not CA breast, not CA breast. So these are the metastatic manifestations. Now coming to the paraneoplastic manifestations. Paraneoplastic manifestations. So paraneoplastic manifestations, they can be because of two reasons. Can be because of hormones, can be because of immunoglobulins, can be because of immunoglobulin. So route of spread, of course, metastasis is spread to the blood. Metastasis is by the blood. So hormones, immunoglobulins. So first is the hormones. Then the manifestation. Metastasis to breast is uncommon, is not a feature to breast. Hormone manifestation, and which type of carcinoma is causing that manifestation and paraneoplastic syndrome. So hormone is ACTH. Manifestation is Cushing syndrome. Is Cushing syndrome. And we all know that in Cushing syndrome, sodium levels are high and potassium levels are low. If sodium levels are high, that leads to increased ECF volume, and that will stretch atria, and atria will release atrial natriuretic peptide, or we can say atrial natriuretic factor. So second hormone indirectly which is increased is ANF, atrial natriuretic factor. Then the main type of carcinoma which leads to increase elevation of ACTH is small cell. Is small cell. Second is ADH, antidiuretic hormone. So the manifestation is SIADH, syndrome of inappropriate ADH release, and that lead to sodium values being low. Sodium is low, and the type of carcinoma is again small. Is small. Then PTH related peptide. PTH related peptide. So this leads to hypercalcemia, and this is because of squamous cell. This is because of squamous cell. And hypercalcemia, what it will do? It will inhibit endogenous PTH. High calcium inhibits the endogenous PTH. So PTH will be low. So the hormone which is low in CA lung is PTH, while PTH related peptide increases. Then hormone, not typically hormone, but we can say humoral factor which is increased is platelet derived growth factor. Platelet derived growth factor, PDGF, and now it is considered as the best theory for clubbing. So the manifestation will be clubbing, and it will be so severe that it can be grade 4, and grade 4 clubbing is known as HOAP, hypertrophic osteoarthropathy, hypertrophic osteoarthropathy. And this is asked in the previous questions, previous exams, and it is adenocarcinoma. So adenocarcinoma is the most common type, leading to HOAP, leading to HOAP. Now coming to the paraneoplastic syndrome due to immunoglobulins, immunoglobulin induced. So the immunoglobulin induced is mainly because of small cell. So whatever is the manifestation of IgG induced, Ig induced, immunoglobulin induced, they will be basically mainly because of small cell. So if site is CNS, it causes dementia and cerebellar degeneration. And remember, these two manifestation of dementia and cerebral degeneration, they are reversible after treatment of CA lung, Then it can affect the eyes, immunoglobulin, and immunoglobulin induced eye damage is a characteristic term known as carcinoma associated retinopathy. Carcinoma associated retinopathy. Then it can be neuromuscular junction, presynaptic, and the syndrome is Lambert-Eaton syndrome. Lambert-Eaton syndrome. Then if it is a glomerular basement membrane, GBM, glomerular basement membrane, so it leads to nephrotic syndrome. It leads to nephrotic syndrome. So remember, all these are the manifestations of paraneoplastic manifestations. Now coming to the investigations. First, we can do a simple X-ray, and a simple X-ray will show us like collapse, can show consolidation, of course pleural effusion, cavity. But remember, these will not be a specific manifestation of CA lung in the chest X-ray. So the question come, which is the most specific chest X-ray finding which will suggest that the cause is because of CA lung? Answer is rib erosion. Rib erosion. So if rib erosion is present along with these findings, so we can say it is because of CA lung. So we can say it is a specific finding in CA lung, rib erosions. Then we can go for simpler test like sputum for malignant cells, And here also we take usually 3, and maybe we can go up to 5 samples. But the sensitivity of this sputum examination is low, 70%, but specificity is 100%, is 100%. So we have to go for those tests where the sensitivity is more. So if X-ray is suggestive of a collapse means it is a central lesion. So we can take the biopsy through bronchoscope. So bronchoscope induced biopsy. And that is mainly helpful for central lesions, and the sensitivity of this bronchoscopy is 85%, is 85%. Specificity again 100%. Then if it is a peripheral lesion, so bronchoscope does not go till the alveoli. So what we'll do, we do CT guided biopsy. CT guided biopsy, and the sensitivity of this procedure is approximately 80% in taking out the lesions, Then of course for metastasis we have to evaluate MRI brain, and of course CT abdomen for adrenal, and for liver is done. So the diagnosis is made. Remember, the carcinoma diagnosis is made on the basis of biopsy only. X-ray will not decide. So biopsy is must for proving a case of carcinoma of the lungs. Now the treatment. Remember staging. You can remember the staging, but it is so complicated, so vast that usually you will forget the important points. So just remember the staging according to the treatment point of view. So treatment, we can divide the patient into 2 groups. One is small cell carcinoma and non small cell carcinomas. The basis of dividing these two into 2 groups is small cell carcinoma. We assume that patient already has metastasis. Patient has metastasis already, and when the patient has metastasis, one modality of treatment is not done, and that is surgery is not to be done. So whenever a case of small cell carcinoma come, surgery will not be done. So this we will divide into. So what will be the option left with us? Option left with us will be chemotherapy or radiotherapy. So small cell carcinoma we will further divide into 2 groups, and that will be localized. Localized means that it is localized to unilateral side, unilateral hemithorax. Diffuse, that means bilateral lungs are involved, and also there is involvement of pericardium. Reason being This classification, this you can say is also the staging. There is no separate staging for small cell like stage 1, 2, 3 or 4, 1A, 1V, like this. There is no staging. It is just localized or diffuse. Localized, one side of the hemithorax. Diffuse, bilateral lungs are involved, contralateral lung is involved, and pericardium is involved. So the basis for this classification is we have to give radiotherapy, and if radiotherapy, there is a port, if that area is captured by that port safely, it is a localized. So if there is to one side, the radiotherapy port will be effective to one side, and that to localized area. Suppose if it is a bilateral disease, radiotherapy port will not be able to encompass both lungs safely, because other tissues will also be destroyed, like in between what is there, heart. So if both the sides of the lungs are involved, radiation will affect the heart, so that causes heart fibrosis, pericardial fibrosis, endocardial fibrosis. So we have to give radiotherapy safely. So diffuse localized means that localized radiation can be given safely, while diffuse radiation can't be given safely. So in diffuse we do not give radiation, while in localized we give radiation. So here we give chemotherapy plus a radiotherapy. While diffuse we give only chemotherapy. And the chemotherapy is basically platinum based, that is cisplatin, carboplatin. So platinum based therapy, chemotherapy is given in cases of small cell carcinoma. Now coming to non-small cell carcinoma, we can divide it into early stage or late stage. So early stage, that means the tumor is small, and the size, just remember the size, there is no need to remember the stages. Size of the tumor less than 4 centimeter, and that less than 4 centimeter will be, we can say, is amenable to surgical therapy. So in early stage, the mainstay of treatment will be surgery, and of course we will give chemotherapy. While in the late stages, that disease is advanced, there is metastasis, so here the only option is chemotherapy. In both the stages, if there is a Pancoast tumor, then we add, this will be done, of course we will add radiotherapy, and that radiotherapy will be only to the Pancoast tumor, because Pancoast tumor is causing nerve damage, and nerve damage can be irreversible nerve damage. So we have to shrink the tumor size, so nerves will be decompressed from the effect of tumor. So the radiation will go only to the Pancoast site. Now coming to the next topic, this was about the carcinoma of the lungs. So next topic is pulmonary vascular diseases. So in pulmonary vascular disease, we usually do two topics. One is pulmonary embolism, and second is Pancoast tumor is unilateral. Because it is posterior, so it can be encompassed easily. So pulmonary vascular disease contain pulmonary thromboembolism and pulmonary hypertension. Pulmonary hypertension. So let's start with pulmonary thromboembolism. So pulmonary thromboembolism, first is what is the site of thrombus which is coming. So if we'll say the most common site, most common site is the deep vein thrombosis of lower limbs. It is the most common site. Now in this question come, what is the most common genetic cause of DVT, deep vein thrombosis of the lower limbs. So the most common genetic cause of DVT is factor 5 laden. Factor 5 laden means that the factor 5 has become resistant to inactivation by protein C. So normally protein C inactivate or inhibit factor 5, but factor 5 has the property, genetic mutation, that it is resistant to inactivation. So in any question, if factor 5 laden is not given but resistance to protein C is given, is the same thing. Is the same thing. Second is the site is renal vein. Is the renal vein. So renal vein thrombosis. Third, ovarian vein thrombosis or prostatic vein thrombosis, and this are basically because of carcinomas. Basically because of carcinomas. Then it can be hepatic vein thrombosis. Hepatic vein thrombosis. Here the question is there. Most common cause of hepatic vein thrombosis, which we also call as classical Budd-Chiari syndrome. Classical Budd-Chiari syndrome. So most common cause worldwide is myeloproliferative disorders, and that include polycythemia vera. Polycythemia vera worldwide. Now it can originate, the thrombus can originate as close to as left atrial thrombus, and it comes to the right side by atrial septal defect. Atrial septal defect it can come, and if it is coming through the atrial septal defect, it will be called as the paradoxical emboli. Paradoxical emboli. Now coming to the what happens in the lungs, pathophysiology, कि how this thrombus is causing so much of mortality, so much of symptoms of the patient. So pathophysiology, this is the right ventricle, and here is the pulmonary artery. Pulmonary artery. So this is alveoli. This is the alveoli. Oxygen in the alveoli. So thrombus has come into the right side and it has say lodged here. So to that particular alveoli, the perfusion is zero. Perfusion is stopped to that alveoli, to that alveoli. So first pathophysiology will be oxygen will be entering into the alveoli, but it is not getting able to diffuse, because for diffusion it needs blood perfusion. So there is no diffusion. Oxygen is coming but not able to diffuse, get exchanged with the blood. No. So that means there is increase in dead space. Increase in dead space because oxygen is not getting transferred. Oxygen is not getting transferred here. So there is, if this oxygen is not coming here, overall, suppose this is a second alveoli, this is normal, oxygen is coming into that part, but that segment is not contributing to the oxygenation of the systemic blood, so here contribution is literally zero from this segment, and ultimately the total amount of PaO2 decreases. PO2 decreases. So this is normal, say 100%, and this is 0. So average is decreased. So dead space, hypoxemia. PaO2 is decreased. PaO2 is decreased. Second, so which type of respiratory failure it will become? It is a type 1 respiratory failure. Type 1 respiratory failure. Now, what happens? There is a hypoxemia, and the property of hypoxemia is that it causes, this is a physiological phenomena, it causes vasodilatation of systemic circulation, but vasoconstriction of pulmonary vessels. Vasoconstriction of pulmonary vessels. So the vessel which was not involved by the thrombus is also narrow down. So oxygen transfer is also reduced from here. Third, from this thrombus there will be autolysis, and there is a release of, due to autolysis, release of platelet serotonin. Release of platelet serotonin from the thrombus. This will release, and this serotonin has the property that it leads to bronchoconstriction. So airways are also affected. So this is a disease of pulmonary vessel, but airways are secondarily affected. There is a bronchoconstriction. Fourth, right ventricle, if there is a thrombus distal to it, so right ventricle workload will increase. Definitely. So if right ventricular workload is increased, it can go into ischemia. That means ischemia is due to two reasons: either blood supply is less or demand is more. So this leads to right ventricular ischemia as workload increases. And this predisposed to right ventricular failure. And remember, right ventricular failure is the most common cause of mortality in pulmonary embolism. So most common mortality in pulmonary embolism is right ventricular failure. Not only right ventricular is affected, left is also affected. Let's see how it is affected. Right ventricular has obstruction distal to it. So more the thrombus near to the right ventricle, more will be the pressure generated in right ventricle. So what will happen? This right ventricle interventricular septum, because of high pressure of right ventricle, it can bulge into the septum can bulge into left ventricle, because there is a obstruction here. There is a obstruction here, so pressure will increase and this will cause bulging of interventricular septum. So if interventricular septum is bulged into left side, cardiac output of left side decreases because of impaired left ventricular filling. Impaired left ventricular filling. So fifth point is interventricular septum bulge into left ventricle, bulge into left ventricle, leading to decreased filling and hence decrease cardiac output. Decrease cardiac output. And remember, this is the interventricular septum bulging into left ventricle that is also responsible for pulsus paradoxus, which is a sign also seen in cases of pulmonary thromboembolism. Now coming to the clinical features. So here question is usually asked, which is the most common symptom? It is dyspnea. It is dyspnea. While other symptom which can be seen is mainly due to peripheral embolization. Peripheral embolization means pleura is involved, and pleura involvement causes chest pain and cough. So patient will have chest pain and cough due to peripheral embolization leading to pleural involvement. Leading to pleural involvement. Now coming to the signs, question is asked, what is the most common sign? Answer is tachypnea. Tachypnea is the most common respiratory sign. While in CVS, yes, we do get signs like increased JVP and pulsus paradoxus, characteristic sign in the CVS finding. Now coming to the investigations. What are the investigations done of a patient of pulmonary thromboembolism? So nowadays the questions which are generally asked on the investigations of pulmonary embolism is the clinical situation. If a patient is coming, what will be the next test and what will be the definitive test? So if a patient is coming with a suspected pulmonary thromboembolism, so we can divide the patient into two groups. Either it is a low risk or patient is in a high risk. So what are the factors which will determine that patient is into a low risk or a high risk? There are 6 points. So scoring is done on the basis of these 6 points. First is signs and symptoms of deep vein thrombosis. If it is present, like there is a swelling of the limbs or tenderness of the limbs, so signs and symptoms of DVT, it is 3 points. No alternative diagnosis On the basis of clinical examination, there is no alternate diagnosis. We'll give it as 3 points. Then heart rate more than 100, we give it 1.5. Then immobilization history for more than 3 days. Remember, after immobilization, it takes 3 days for deep vein thrombosis to occur and pulmonary embolism to occur. So we give 1.5. If previous history of pulmonary embolism positive, we give 1.5. We give 1.5. Then if there is hemoptysis, 1 number, cancer history, 1 number. So these are the scoring. So according to the clinical case, if we add and the score is coming to more than 4, the patient is in high risk. Patient is in high risk. More than equal to 4, we can say. Low risk is less than 4. Less than 4. So if a patient is in a low risk group, the next test that we will do will be a D-dimer test. D-dimer test. And D-dimer test, remember, is the best screening test. Means it has got a very high sensitive value, highly sensitive, but it is false positive in a very large number of cases. So low risk and D-dimer is negative. Low risk and D-dimer is negative. That means investigate for other causes of breathlessness. So alternative diagnosis will be there. Safely we can say low risk, D-dimer negative, nothing to be done for pulmonary embolism. But if it is positive, then go for, remember, D-dimer will not make a diagnosis of pulmonary embolism. We have to go for the test which is used to diagnose pulmonary embolism, and nowadays the test has changed. This is also known as the best investigation to diagnose pulmonary thromboembolism, and answer is multi detector CT scan. So MD CT scan. This is now considered as the best test to diagnose pulmonary embolism. And when the patient is in high risk, then there is no need to do D-dimer. Straight away go for MD CT scan. Directly go for a CT scan to prove that it is a case of pulmonary thromboembolism. So in this way we can do. But if CT scan is not available, suppose, so the second line test that we can do is ventilation perfusion scan. Remember, it is now second line test. But the first line and the best test is multi-detector CT scan. Now the importance of other investigations, let's see. Other investigations, they are mainly for academic point of view. ECG. If question come, what is the most common ECG finding? Most common ECG finding will be sinus tachycardia. Will be sinus tachycardia. But if question come, what is the most specific ECG finding? So that is a typical pattern in which there is a deep S wave in lead 1. There is a Q wave in lead 3, deep Q wave, and T inversion in lead 3. So this pattern is known as S1 Q3 T3 pattern. This is the most specific for pulmonary embolism. Most common sinus tachycardia. Now in the chest X-ray, so that depend on the size of the thrombus. If it is a large thrombus means ki main pulmonary artery is involved. This is the chest X-ray. This is the artery, and the thrombus is a large thrombus here. So what will happen because of this thrombus? The proximal part of the pulmonary artery, it is becoming prominent. So this segment of pulmonary artery, it become prominent. So this is known as Pala's sign. It means prominent pulmonary artery. And the significance is it is a large thrombus. Then if it is a medium sized thrombus, medium size means कि suppose this is a blood vessel, medium size, it is giving out the branches, distal branches, and normally these branches are visible on the chest X-ray. But if there is a thrombus here, so distal branches will become invisible, they become collapsed. So the distal segment will be devoid of the blood vessel. So this we call it as focal oligemia. This portion is known as focal oligemia because distal portions of blood vessels, they will not be visible, and this sign is known as Westermarck sign. So this is the second sign in the chest X-ray, Westermarck sign, and it is due to involvement of the medium sized vessels. Now coming to when it is a very small thrombus. So that means small thrombus is embolized to the peripheral part. So this is the diaphragm. Small thrombus. So small thrombus means somewhere here, and the small thrombus that leads to the collapse, or we can say a wedge shape area which become opacified. So this thrombus causes opacity of wedge shape area, and this wedge shape area is just overlying the diaphragm. So when we'll see then the diaphragmatic opacity, wedge area opacity will look similar. So these will look similar like this. So we see a tenting of the diaphragm like this. We will see that this vase shape area is a part of diaphragm and there is a tenting of diaphragm. So tenting of diaphragm is known as Hampton's hump. Hampton's hump. These are the investigations. But if for theoretical point of view, someone asks you what is the gold standard investigation for pulmonary embolism. Gold standard investigation is pulmonary angiography. Pulmonary angiography, gold standard. Gold standard means ki it is the highest and investigation, and from that investigation we compare other investigation. But gold standard might not be available everywhere, might not be safe, might not be cheap. So it may not be the best investigation. So the best investigation is CT scan. Best is CT scan. Now coming to the treatment part of pulmonary embolism. So the treatment has now simplified, and it is now on the basis of blood pressure. So if blood pressure is normal, it means that the thrombus is a small thrombus. Because it is localized peripherally, and there is no hemodynamic compromise. Right ventricular outflow is maintained and left ventricular outflow is maintained. So it is small thrombus. And remember, small thrombus, they are autolyzed by the body. So there is no need to treat this pulmonary embolism. So there is no need for any thrombolysis. This thrombus will dissolve automatically, but we have to prevent another attack of pulmonary embolism. So we go for secondary prevention. So whatever thrombus has lost, do nothing for that thrombus. So, but we have to prevent further attack. So secondary prevention is done, and we give anticoagulants. Usually given for 3 to 6 months. While if BP is low, that means ki thrombus is most probably a large thrombus. Which is causing hemodynamic compromise, compressing the left ventricle. So now here we have to lyse this thrombus. So we go for primary treatment of pulmonary embolism, and primary treatment is thrombolysis. And thrombolysis commonly is done with LT place. And remember, unlike a case of myocardial infarction, remember, in myocardial infarction, thrombolysis is done up to 12 hours of presentation or 12 hours of chest pain. But here, thrombolysis can be done if there is any indication. It can be done up to 2 weeks. So much of time. So up to 2 weeks we can do thrombolysis for a case of pulmonary thromboembolism. Now the second pulmonary vascular disease is pulmonary hypertension. So scar tissue do not contain gland tissues. How is adenocarcinoma most common type? It is a nidus. it is a nidus, that means the stimulus for the carcinoma formation, and carcinoma will be adenocarcinoma. So this is a nidus, the site, and that stimulate the adjacent gland tissue to produce adenocarcinoma. So pulmonary hypertension, first is the classification. So classification is first pulmonary, role of IVC filter in pulmonary thromboembolism prevention. Remember, there are only two indications of IVC filter. First, if patient has bleeding disorder, so in bleeding disorder we can't give anticoagulants to prevent a second attack. So if patient has bleeding disorder where anticoagulants can't be given, put IVC filter. Second indication is despite anticoagulation therapy, there is a recurrent pulmonary embolism, then it become an indication for IVC filter. So first is when we can't give anticoagulants, and second when we are giving anticoagulant but they are not effective, then we put IVC filters. So classification is pulmonary artery hypertension. Remember here the portion of the pulmonary artery pulmonary hypertension is this portion. It is towards the right ventricle from the alveoli, so that is pulmonary artery hypertension. So the classical feature is pulmonary capillary wedge pressure is normal here, because this is the left atria. So pulmonary capillary wedge pressure is because of left atria. This affect the venous side and this is the arterial side. So pulmonary artery hypertension where pulmonary capillary wedge pressure is normal. Or examples are genetic. And here the question came, what is the most common gene mutation? And most common gene mutation causing pulmonary artery hypertension is bone morphogenetic protein receptor 2 gene. So this is the gene which is responsible for, we can say, artery constriction of the pulmonary side, arterial constriction. So this is the gene BMPR, responsible for pulmonary artery hypertension. Then pulmonary artery hypertension can be a direct effect of HIV. So the only infection pulmonary artery hypertension is HIV. Then it can be because of drugs, and these drugs are usually amphetamines. Then pulmonary artery hypertension can be because of connective tissue disorders, and unknown mechanism. Portal hypertension predisposed to pulmonary artery hypertension. So portal hypertension predisposing to pulmonary artery hypertension, but mechanism is not known, but associated with pulmonary artery hypertension. Then second is pulmonary venous hypertension. So of course pulmonary capillary wedge pressure will be increased. This is connective tissue disorders like SLE, rheumatoid arthritis. These are the disorders. So pulmonary venous hypertension where pulmonary capillary wedge pressure is high, that is because of left atrial pressures are high. So this side is affected, and answer here the options are left ventricular failure, left atrial pressure is high because of mitral stenosis, maybe because of mitral regurgitation. Then it can be because of systemic hypertension, Systemic hypertension putting the pressure on left ventricle putting the pressure on left atria, and hence pulmonary venous hypertension. Pulmonary venous hypertension. Then third is pulmonary hypertension due to chronic hypoxic states. And here pulmonary capillary wedge pressure is near normal, because these hypoxic states, they are affecting the mainly the arterial side. So included in this category is COPD, interstitial lung diseases, yani pulmonary diseases are included in this category. Then fourth, pulmonary hypertension due to chronic pulmonary thromboembolism. Chronic means more than 3 months. So it is recurrently causing the obstruction, recurrently causing the increased pressure of the arteries, And fifth is miscellaneous cause, which include sickle cell disease, which include sarcoidosis, which include histiocytosis, and so on. So these are this is a new classification of pulmonary hypertension. But here we will talk about primary pulmonary hypertension. Primary pulmonary means कि that hypoxic related diseases are ruled out. Pulmonary embolism is ruled out. Miscellaneous causes are ruled out. So that will be primary pulmonary hypertension, and that is basically the classification number 1 of primary pulmonary hypertension. So let's see what are the primary pulmonary hypertension. Clinical features. So symptom wise, most common symptom is a progressive dyspnea, and the onset of dyspnea is on an average 1 to 2 years. So this is a classical history. And the main is progressive dyspnea, most common symptom. Then other symptom can be because of pulmonary hypertension, there is a right ventricular failure, and that lead to edema. Due to right ventricular failure. But this is a late finding. While in the signs, remember, when we do all the signs of inspection, palpation, percussion, auscultation, the respiratory signs are surprisingly normal. We will not find, because it is a pulmonary hypertension, so we will not see any crepitations, any rhonchi, no percussion defect, no mediastinal shift. So respiratory sign will be normal. So basically the signs that will be seen of primary pulmonary hypertension will be in the CVS. In the CVS, JVP will be elevated. Because of right ventricular failure, there will be a murmur of tricuspid regurgitation. There will be edema. So these will be the signs. So respiratory system sign wise will be spared. Classically. Now the investigations. So a patient of progressive dyspnea is coming, and we have ruled out the systemic causes like anemia, thyrotoxicosis. So these has been ruled out. So our focus is either it can be a respiratory problem or a cardiac problem. So looking at the respiratory condition, our first investigation will be chest x-ray. If chest x-ray is showing the pattern, like if it is abnormal, abnormal means hyper inflation, a reticular shadow, so investigation, patient is coming with progressive dyspnea, do chest x-ray. Chest x-ray is abnormal like hyperinflation, reticular shadows. That means it will be a case of COPD or interstitial lung diseases. But if chest x-ray is normal, suppose, then it could be a respiratory condition like pulmonary vascular disease or a cardiac disease So here what we'll do, we will do spirometry, and if spirometry shows that the parameters like FEV1, FVC, they are normal, or FEV1 is reduced or FVC is reduced. So sometimes what happens कि few cases of say bronchitis or few cases of ILD might not be detectable on X-ray, so do spirometry. So if spirometry shows abnormal results, then it can be a case of ILD, it can be a case of COPD if they are not detectable on the chest x-ray. But if spirometry is absolutely normal with a normal chest x-ray finding, so the next test that we will do is DLCO. So a patient of progressive dyspnea is coming and suspected of pulmonary embolism, chest x-ray normal, spirometry normal, do a DLCO. So this DLCO is low with a normal spirometry. It will suggest pulmonary vascular disease. That we have done in the PFTs in the earlier lecture. The DLCO was low but spirometry was normal. So here suspicious of pulmonary vascular disease, so the next step will be pulmonary angiography, and with pulmonary angiographic procedure we measure the pulmonary pressures and we can say this is the confirmatory test for pulmonary hypertension. DLCO last time we have discussed diffusion lung capacity for carbon monoxide. That is reduced in cases of pulmonary vascular diseases. Now diagnosis is made. Coming to the treatment. So treatment is we have to dilate the pulmonary vessels, we have to reduce the pressure. So usually we start with the safer agents. So we give vasodilators, and that is calcium channel blocker. they are relatively economical, they are safe agents, so we give either nifedipine or we can give amlodipine for pulmonary hypertension, for pulmonary hypertension. Then also we can use for pulmonary vasoconstriction endothelin receptor antagonist. The property of endothelin is vasoconstriction, so we will give the antagonist, and it is bosentan and ambrisentan is given. So these two groups of drugs vasodilator and the endothelin receptor antagonist, we usually start with these agents. But if patient still not responding, then we can go for phosphodiesterase 3 inhibiting agents, and they also cause vasodilatation. And included drug is sildenafil and tadalafil. So these will be the therapy. But if still patient is refractory with this therapy, then we give prostacyclin analogs, and drug is iloprost. So this is the maximum medical therapy that we can give. But if patient is not responding, we go for lung transplantation. So what will be the indications of lung transplantation? Lung transplantation indication in pulmonary hypertension is progressive right ventricular failure despite prostacyclin therapy. Progressive right ventricular failure despite prostacyclin therapy, we go for lung transplant. And remember, it is a bilateral transplant. Unilateral will not be effective. Mandatory bilateral transplantation of the lungs. So these are the two pulmonary vascular diseases. Now coming to pneumonias. So starting with what are the causes of pneumonia. So for that we have to divide first pneumonia into different groups. So causes, we can divide it into the two groups. Drug of choice for pulmonary hypertension, CCB or bosentan. Remember, exactly there is no drug of choice. The thing is, if a patient is vasoreactive, that means what we'll do during pulmonary angiography, we give vasodilating agents and see the response during the procedure, during the diagnostic procedure. If pulmonary artery pressure falls by more than 10 millimeter of mercury, it means patient will respond to vasodilating agents, and in that the drug of choice will be calcium channel blockers. But if patient is not vasoreactive, then there is as such no drug of choice. We have to go by hit and trial. CCB is bosentan, phosphodiesterase 3 inhibitor, then we go according to that. So if patient is vasoreactive, vasoreactive means fall of pulmonary artery pressure by more than 10 millimeter of mercury after vasodilating agent, more than 10 is vasodilator. In that case, drug of choice is CCB. Reason being, CCB are cheaper, less side effects. Bosentan is a costly drug, So for that we can mark CCB safely. Now pneumonia causes. We can divide into two broad cause. First will be community acquired, and second will be hospital acquired. Hospital acquired. Now community acquired, we can classify it into typical pneumonia and atypical pneumonia. Typical pneumonia means the patient in the chest X-ray will have consolidation, and the symptoms, they will match with the chest X-ray findings. And usually no systemic manifestations or unique clinical systemic feature will not be seen. So consolidation symptoms means if X-ray shows a large amount of consolidation, symptom will be more. X-ray shows little consolidation, symptom will be less. But in atypical, there is no consolidation, symptoms are much more than the X-ray findings. X-ray finding will be minimal, but symptom will be very high, and usually systemic features positive. So this will be the difference between a typical and a atypical pneumonia. Let's come to the causes. Most common cause of typical pneumonia is Streptococcus pneumonia. Other causes are H. influenza, Staph aureus, Klebsiella are the other organisms. Now coming to the atypical pneumonia, most common organism causing atypical pneumonia is Mycoplasma, and sometimes it is also known as walking pneumonia. Because usually when patient comes with means ki very less symptoms initially, comes walking and immediate deterioration. Other organisms here are chlamydia and Legionella. Of course, viral pneumonias are also atypical pneumonias. Now, coming to the hospital acquired pneumonias. So in this category, we can divide the patient into two groups again. First will be ventilator associated pneumonias, and non-ventilator associated pneumonias. Short form VAP, usually given in the question like VAP, ventilator associated pneumonia. So what are the organisms here? If ventilator associated pneumonia occur early means within we can say 5 days of ventilator, early. So here the organisms are usually sensitive to antibiotics. sensitive to antibiotics, and here the most common organism is Streptococcus pneumonia. Other organisms are methicillin sensitive Staph aureus. Methicillin sensitive Staph aureus. Klebsiella. Early VAP, but if it is a late VAP, more than 5 days, it is a drug resistant case. So organism is Pseudomonas, most common. Other organism, methicillin resistant Staph aureus, and other drug resistant Enterobacteriaceae species. Enterobacteriaceae species, methicillin resistant Staph aureus, but the most common will be Pseudomonas aeruginosa. Pseudomonas aeruginosa. Now non-ventilator associated, that means ki there was no ventilator produced done in the patient, no procedure was done, but still patient has got the infection, and here the most common organism is Staph aureus. Now coming to the other causes which are dependent on the host factors, dependent on host factor ki which pneumonia is common in which age or which are the categories of patient. So host factor and the organism. So the host factor is say let's start with the age first. Age less than 6 months. So in this age group usually bacterial infections are less because maternal antibody protect the child for 6 months or so, antibodies. So here the organism will be virus, and that is respiratory syncytial virus. Respiratory syncytial virus. If adult patient, here the organism is Streptococcus pneumonia. If elderly means more than 65 years of age, more than 65 years of age, so the organism here is usually Mycobacterium TB. If there is neutropenia, organism Pseudomonas. In cases of bronchiectasis, organism will be the same, Pseudomonas aeruginosa. Then commonly asked question, cystic fibrosis. Cystic fibrosis patient. So in this patient the organism will be dependent on the age. If it adult patient, organism is a typical form of Pseudomonas which is known as mycoid strain of Pseudomonas. Mycoid means ki this is the Pseudomonas bacilli, and because of repeated antibiotic, what it is doing, it is secreting a mucus layer around it. Mucus layer around it, around the bacilli. So antibiotic penetration is not effective. It is not effective. So we can say mycoid form is antibiotic resistant. But if it is a child and the age of the child is less than 12 years, case of cystic fibrosis, organism is Staph aureus. And for completion point of view, just remember that in cases of cystic fibrosis, Mycobacterium TB is a rare entity. So Mycobacterium TB in cystic fibrosis is rare, Now the other host factors, and importantly, is the HIV. So if nothing is mentioned in HIV and it is asked most common cause of pneumonia in HIV, answer is it is Streptococcus pneumonia. But if CD4 counts are given, say CD4 count is less than say 200 to 500 with HIV, the most common organism will be Mycobacterium TB. CD4 count is 50 to 200. Here it is Pneumocystis carinii. Pneumocystis carinii. And if it is less than 50, it will be Mycobacterium avium intracellular. Mycobacterium avium intracellular will be the organism. Now, if host factor is given as AC plant worker, the organism will be Legionella. So these are the different organisms according to the host factors. Now coming to the clinical features. Symptom. Yes, of course it will be fever, cough and sputum. So on the basis of the sputum color, we can identify the organism. If sputum given is a rusty sputum. So remember, rusty sputum is due to large number of RBC being destroyed in consolidation, and large number of RBC come when there is a full one lobe of the lungs are involved. So it is a case of lobar pneumonia, and the most common organism which is causing lobar pneumonia is Streptococcus pneumonia. Streptococcus pneumonia, a rusty sputum. When it is a green colored sputum, it is by the pigment of Pseudomonas. And when it is given as sputum color, red currant jelly. This is a typical description of blood which has slightly clotted, so it produces jelly. It produces a jelly sort of thing, and that is suggestive of Klebsiella. And when there is a red sputum without blood, it is also known as pseudohemoptysis. And that is suggestive of serratia, pigment of serratia. Now, cytomegaloneumia at what CD4 count level? It will be 200, 250. So middle category 50 to 200. Then science, the typical description of a case of pneumonia is in the inspection. Remember, pneumonia or consolidation does not lead to mediastinal shift. That is a very important finding. Mediastinum will be central. While palpation, vocal fremitus is increased because of consolidation. Percussion will be dull, and auscultation will show bronchial breath sounds. Now coming to the clinical features of atypical pneumonia. So in the classification, there was a point that atypical pneumonia do cause systemic features. So let's do what are those systemic features, and we'll try to identify the organism. So clinical feature, and this is about atypical pneumonias organism. So there is autoimmune phenomena going inside the body. Autoimmune phenomena, and this autoimmune phenomena include Coombs positive hemolytic anemia. It include Guillain-Barré syndrome. It include transverse myelitis. So also there can be hepatosplenomegaly, also seen. So these autoimmune things are caused by mycoplasma. So this is the organism, mycoplasma. Now if clinical features are relative bradycardia, there is SIADH and diarrhea, and we know SIADH causes hyponatremia. So these clinical feature, systemic features, are due to Legionella. While if there is a false positive VDRL, there is hepatosplenomegaly again, and this is one of the infectious cause of coronary artery disease. False positive VDRL, hepatosplenomegaly, and coronary artery disease. It is a case of chlamydia. And remember, for all these atypical pneumonia, bacterial pneumonia, the drug of choice is macrolides. Now coming to the investigations of pneumonia in general. So investigation, first we'll do the plain chest X-ray. So if chest X-ray shows that there is first pattern, homogeneous opacity with sharp margin. This is the description, and when we'll see the chest X-ray, like if we'll see one side, so there is homogeneous opacity, that means with a sharp margin. This is the lobe which is involved. uniformly involved, uniform opacity, and a sharp line separating it from the other lobe of the lungs. So, this is a classical description of lobar pneumonia. And most common organism we all know, Streptococcus pneumonia. Streptococcus pneumonia. Now, if there is a typical description of upper lobe infiltration, which we'll see suggest कि it can be tuberculosis, but there is bulging of interlobar fissure. So in between the lobes there is a bulging. So if we'll see the X-ray like this, there is a bulging of say this fissure, interlobar fissure. There is a fluid in it. There is a fluid in it, and there is a upper lobe infiltration. Upper lobe infiltration. So this is highly suggestive of a Klebsiella pneumonia. Klebsiella pneumonia. Then if there is description like this, small air spaces with thin wall, multiple small air spaces with a very fine and thin wall, this is known as pneumatocoel. This is known as pneumatocoel. So this pneumatocoel is characteristically caused by Staph aureus. This is characteristically caused by Staph aureus. Then there can be a description in the X-ray like cavity. Cavity is we can say a type of air space with usually thick wall, and it is at least 2/3 circumference is complete. Air space with a thick wall, at least 2/3 of the circumference is complete. So in the X-ray what we'll see, because this cavity are originating from the airways, so might not be ki completely we get. So this is like the cavity. At least 2/3 circumference will be complete, at least. This defines the cavity. This cavity can be empty cavity or that can contain fluid in it. So if it is containing fluid in it, we will call this as the air fluid levels which can be seen. So the cavity caused by almost all infections except, so we should know the infection which does not cause cavity, and it is viral pneumonias, it is chlamydia. They are the organism which does not lead to cavity formation. Cavity formation. Now rest of the test, that was the chest x-ray for pneumonia. Rest of the test like sputum, we send sputum for AFP, gram stain. Gram stain mainly basic idea is to select empirical antibiotics and culture to choose definitive antibiotics. While there are some organisms whose antigen, or these organisms, they are excreted through urine. They are causing pneumonia, but they are excreted in the urine. So we can say a very atypical test in spite of respiratory system, we do a urine test. So urinary antigens. Two bacteria can be detectable in the urine, Legionella and Streptococcus pneumonia. Pneumonia. Then blood culture. Blood culture, remember, has got a very low sensitivity, less than 15%. So it is usually not giving us much of information. Blood culture. Sensitivity less than 15%. Less than 15%. Now the treatment. So the treatment consists of where the patient should be treated, and for that we need to know the severity of pneumonia. So treatment will be decided by the score of pneumonia, and scoring system is curve 65. Curve 65. So it is 15%. It is 15% sensitivity. Air bronchogram, that you will see in the x-rays and also will be covered in the radiology section. Score curve 65. Curve 65 means C stands for confusion. If it is present, score is 1. U, urea elevated, blood urea elevated. Present, score 1. R, respiratory rate. Respiratory rate more than 30 per minute. More than 30 per minute. It is 1. It is 1. Viral pneumonia usually affect which part of the lungs? Remember, viral pneumonias affect the mainly alveoli. They mainly attack the diffusion system of the oxygen in the lungs. So it produces a alveolar damage more. So alveoli are very small particles. So on the X-ray we might not see any change. So X-ray will be near normal, but patient will be highly symptomatic. So it is the main part of viral pneumonia is bilateral diffuse alveolar involvement. Alveolar involvement. And second part that virus affect is the small airways. Small airways like bronchioles. Bronchioles. Therefore we will say bronchiolitis is basically because of viral infections. Viral infections. So virus affect the peripheral part of the lungs and the small airways. Now respiratory rate more than 30 per minute, present 1. Then B, that is blood pressure. If blood pressure systolic BP is less than 90 and diastolic BP is less than 60. If both are present or any one of the two are present, positive, 1 score. 65 means age more than 65. Present 1 point. Present 1 point. So the score is 5. Score is 5. So let's see what are the antibiotics that we give according to the score. So we'll make a table. Score, site of care, whether it is OPD, ICU or admitted patient. Then antibiotic to be given, and what is the, that question has come last year in All India, mortality rate for that particular score. So if score is 0, 1, the site of care, this is a mild type of pneumonia, it can be treated in the OPD. Treated in the OPD. Antibiotics given here is usually macrolide or fluoroquinolones. And the mortality rate is very minimal. The maximum mortality which can go is 1.5%. 1.5% maximum. Then score is 2. Site of care is inpatient department, admitted patient, and here antibiotic we give is IV fluoroquinolones. And the mortality rate with this score of 2 is 9.2%. 9.2%. While score is more than equal to 3. More than equal to 3. So the site of care is ICU. And here antibiotic given are IV cephalosporin plus IV fluoroquinolones. This is a combination. Or IV fluoroquinolone can be replaced with macrolide. Even in ICU we can give macrolide. So combination of the drugs is given. Mainstay of treatment is the cephalosporin. And here the mortality rate is high. It is 22%. 22%. So this was about the topic of pneumonia. So finally we come to the last section of respiratory system, and that is pleural effusions. Pleural effusions. Starting with the causes of pleural effusion. So any special drug for pneumocystis carinii pneumonia? Yes, we do not give routine antibiotic. Pneumocystis pneumonia we treat with cotrimoxazole. Cotrimoxazole is the drug which is used for pneumocystis carinii pneumonia. Though it is a fungus, but it does not contain ergosterol wall. So ergosterol wall is sensitive to antifungals. So this is not sensitive to antifungals. So yes, there are new drugs which has come, but the efficacy is not so good to these new drugs. Like macrolides can be used, antimalarials can be used, primaquine can be used for pneumocystis carinii, but the effect is not so that then the effect which has come with the sulfonamides, for the sulfonamides. TB is a topic which is best covered in PSM, which is best covered in PSM. So tuberculosis and also systemically, like tubercular meningitis, spinal tuberculosis, so it affect different systems. So you do it from the signs and symptoms from the different symptoms, but the best part will be the PSM part of pulmonary tuberculosis, and especially the categories of tuberculosis, the treatment which has changed, the tuberculosis programs, they are very important for tuberculosis. Cystic fibrosis, it's a pediatric topic, and hydropneumothorax is a surgical topics. So pneumothorax in general, management, causes will be covered in the surgical part. So we are left with the medical part of the pleural effusion. So causes, there are two broad causes of pleural effusion. First is the transudative cause. Transudative cause mechanism. So we can say the thing which is not exudative is transudative. So transudative means कि this is the pleural space and this is the blood vessel. So fluid has come from blood vessel into the pleural cavity mainly because of increase hydrostatic pressure or decrease oncotic pressure. So causes of transudative, most common cause, important MCQ, is left ventricular failure, and the mechanism here is increase hydrostatic pressure. Then other causes are cirrhosis, nephrotic syndrome, and here the cause is decrease oncotic pressure, and characteristically peritoneal dialysis. Occupational lung disease, last time we covered asbestosis, silicosis, berylliosis, they were the types of interstitial lung diseases. So these are the important diseases. So peritoneal dialysis, it is because of increase hydrostatic pressure from peritoneal cavity. Through diaphragm. Peritoneal dialysis. So the hydrostatic pressure is generated from below and they transfuse through diaphragm and affect the peritoneum. Also possible but rare pulmonary thromboembolism, and that is because of increase hydrostatic pressure. Increased hydrostatic pressure is because of left ventricular dysfunction, and back pressure changes leads to the transudative effusion. So here mark this condition, pulmonary thromboembolism. This will again come as a cause of pleural effusion. So these are the transudative effusions, and as such there is no criteria to label it as transudative. It is just the mechanism and rule out the exudative causes. So second cause is the exudative cause of pleural effusion. So exudative is defined by Light's criteria. Defined by Light's criteria, and that Light's criteria is any one of three features can be present. any one of the three features can be present, and these are first, exudative means a sort of inflammatory reaction, can be infectious, can be non-infectious conditions. So in any inflammatory, proteins are increased. So pleural fluid protein divided by serum protein, if it is more than 0.5, it is exudative. Second, pleural fluid LDH. Remember, LDH is also increased in inflammatory reactions, divided by serum LDH more than 0.6 is exudative criteria. Then third, in these two, what we have to do, we have to take the serum values also. But in third criteria, there is no need to calculate the serum values. So that is pleural fluid LDH is more than 2/3 of upper normal limit of serum LDH. So we know the range of the serum LDH. So if it is more than 2/3 of the upper normal limit of serum LDH, it is a exudative pleural effusion. Now, causes of exudative pleural effusion. So most common cause, if question comes, of exudative effusion is infection. And in infection, the most common is bacterial. That means bacterial pneumonia, para-pneumonic. That means there was a consolidation or a bacterial pneumonia, and simultaneously pleura was also involved, and that is surprisingly more common than tuberculosis, even in India, and more than tuberculosis, more than viral pneumonias. So this is the sequence of infection. Most common is para-pneumonic effusions. Now coming to second cause, malignancy. Malignancy, again question asked, most common malignancy CA lung, more than CA breast, more than lymphoma. So these are the three most common causes of malignancy causing pleural effusion in this sequence: CA lung, CA breast, lymphoma. Now third is GIT cause. That means primary pulmonary disease was absent, and GIT cause causing effusion. Important are acute pancreatitis. So inflammatory process spreading to the pleura. Esophageal rupture. Then subphrenic abscess. Then gynecological cause, और इसमें the typical gynecological cause is Meigs syndrome. Meigs syndrome is ovarian tumor plus ascites plus usually right-sided pleural effusion. Right-sided pleural effusion, Meeks syndrome. Then fifth cause of exudative is the drugs. So drugs causes a sort of allergic reaction which is inflammatory reaction and leading to pleural effusion. So drugs implicated are very few drugs for pleural effusion, and alphabet wise if we will see, A means amedron, B bromocriptine, then there is no C, D dantrolene, again D dasatinib. Dasatinib is a new drug which has come for malignancy CML, chronic myeloid leukemia. Imitinib though is the preferred first line drug, but this can be also replaced dasatinib. Then M and N. M is methyl sergide and N is nitrofurantoin. Nitrofurantoin. Then cause number 6 for exudative are the parasites. Yes, parasites do affect lungs, and again they causes allergic reaction, eosinophilic reactions, and these parasites are Strongyloides, Ascariasis, So most common cause of pleural effusion is transudative or exudative. Remember, if this question come, most common cause of pleural effusion, answer is left ventricular failure. That may not cause clinical effusion, but ultrasound wise we can get a fluid. So the most common cause overall out of transudative and exudative will be transudative, and most common cause if it is not given transudative or exudative will be left ventricular failure. Causes of unilateral pleural effusion, that will come after doing these causes, which are the causes that lead to right sided, which are the causes that leads to left sided effusions. So parasite, Strongyloides and Ascariasis. Then autoimmune disorders, and these include SLE, that include rheumatoid arthritis, and that include Churg-Strauss syndrome, autoimmune conditions. Then 8th one is only pneumoconiosis causing pleural effusion, and that answer is asbestosis. Meeks syndrome, exudative pleural effusion, what is the reference? Reference is Harrison textbook of internal medicine 18th edition and the table of pleural effusion. So asbestosis is the only pneumoconiosis that is causing pleural effusion, Then post CABG, post coronary artery bypass graft, So this causes a type of hyper sensitivity reaction. That means a type of eosinophilic response, type of eosinophilic response. So it have eosinophils mainly in the effusion. Now the 10th is PTE, pulmonary thromboembolism. That was also responsible for transudative also, and it also caused exudative by causing inflammatory process in the pleura, distal ones. But in pulmonary embolism, remember, exudative is more common than transudative, is more common than transudative. So this is the only cause which can present with both type of effusions, both type of effusions. Now, which are the effusions which are right sided, and the effusion which are left sided? Unilateral effusions. So right sided effusion is due to ruptured liver abscess. It is because of Meeks syndrome. It is because of right sided subphrenic abscess. While left sided is because of acute pancreatitis. It is because of esophageal rupture. And of course, left sided subphrenic abscess. Subphrenic abscess. So Dressler syndrome is transudative or exudative. Remember, Dressler syndrome is mainly pleuritis, and this is hypersensitivity reaction. So Dressler syndrome is a type of exudative. Dressler syndrome is hypersensitivity reaction occurring 2 to 4 weeks after myocardial infarction, 2 to 3 weeks after. So pericarditis can occur, pleuritis can occur, and this is because of hypersensitivity reaction. So it will be exudative one. It will be exudative one. Now coming to the clinical features, symptom wise, it will be cough, chest pain, and the symptom of dyspnea is late. Remember, in pleural effusion, dyspnea never come in the beginning. In the beginning, they are basically cough and chest pain. These are early symptoms. Early symptoms. And signs we have already done of pleural effusion when we did the malignancy part, CA lung, ki what will be the feature of pleural effusion on the signs. So straight away coming to the investigations. So the mainstay of investigation is chest X-ray and pleural fluid analysis. Pleural fluid analysis. So looking at chest X-ray. So here the question is asked, the earliest change is seen in which view? Earliest is seen in lateral view. Earliest change. So what will be the change? So this is a lateral view, for example. This is the posterior side and this is the anterior side. So we are taking the X-ray from the lateral side. So the diaphragm is anteriorly, it is attached more upwards, and posteriorly it is down, diaphragm. And pleura follows the diaphragmatic portion, so it will go like this, Whatever the fluid is collected, this fluid with the effect of gravity will be accumulated in the posterior part. So posterior part become blunted. So this is blunting of posterior costophrenic angle, and the minimum amount of fluid which is required is 75 ml, to cause blunting of posterior costophrenic angle. But when we do the PA view, in PA view, earliest change is blunting of costophrenic angle, So earliest change is blunting of CP angle, and minimum fluid required to cause this blunting is 175 ml, is 175 ml is the fluid required. Now as fluid start accumulating in the chest x-ray, so these are the diaphragms. So if fluid has accumulated and that has obscured the diaphragmatic opacity or diaphragm, so obscure diaphragm, the amount of fluid needed is 400 ml. 400 ml. Now second important investigation, mainstay of investigation, is the pleural fluid analysis. If unilateral, then also minimum fluid is 175. Remember, this is the ml to that side, whether it is unilateral or bilateral. Lungs are two different organs. There are two lungs. So there will be two pleura, two CP angles, two posterior angles. So the amount of fluid will be 175 ml. Now second is fluid analysis. So first we'll do TLC, total leukocyte count. If it is more than 1000 per microliter, it is suggestive of, not diagnostic, but suggestive of exudative. Then DLC. DLC, the different types of cells that we can see. Neutrophils. Predominant cells are neutrophils. So that is characteristically seen in parapneumonic effusions, that is bacterial effusions, that is seen in GIT causes. All three that we have discussed, neutrophils. Then lymphocytes is seen in majority of the non-bacterial causes like TB, viral, malignancy. But characteristically, eosinophil predominance. Eosinophil predominance is typically seen in cases of drugs, parasites, chug straws, it is seen in cases of asbestosis that we touched last time in the asbestosis section. Then it can be seen in post coronary artery bypass. It is a hypersensitivity of eosinophils. So these are the causes of eosinophilic predominant pleural fluid. Predominant pleural fluid. Then basophil predominant, and that has a very only one cause, leukemias. Leukemias. Exact mechanism not known, but highly typical of leukemic pleural effusion. Leukemic pleural effusions. Now coming to the other parts, sugar in the pleural fluid. Sugar in the pleural fluid. So it can be low, it can be high. Low is said when the pleural fluid glucose is less than 60 milligram per deciliter. 60 gram per deciliter. High when it is more than blood sugars. So the fundamental of low sugar is if there are rapidly dividing cells which consume sugars. Rapidly dividing cells which consume sugars. So this is typically seen in pneumonia effusions. This is typically seen in malignancy, rapidly dividing cells, and in cases of empyema. Empyema means gross pus in the pleural fluid. Gross pus in the pleural fluid. Then characteristically, rheumatoid arthritis. Rheumatoid arthritis. So high more than the blood sugar. It is typically seen in cases of peritoneal dialysis. Because in peritoneal dialysis we are giving glucose rich fluid in the dialysis fluid. So it is glucose rich. So that glucose reaches the pleura and causes high blood sugar level, peritoneal dialysis. Now other test that we can do for proving exudative and transitive that we have done, we did proteins, we did LDH. But we also have to order for the pH, and this is an important test which is usually ignored in cases of pleural fluid. pH if less than 7.20, it is indicative of pneumonia effusion, empyema, and rheumatoid arthritis. So important parameter. Why? Because if pH is less than 7.2, it indicate that in cases of infectious causes, in cases of infectious causes, there is high likelihood of pus formation. Pus formation. So even if patient has parapneumonic effusion, gross pus is not seen, but pH is less than 7.2, it become indication to put chest tube drain, because in empyema the main treatment is chest tube drainage. Pus has to be drained out. Even if it is not gross pus but parapneumonic, pH of less than 7.2, indication of chest tube insertion. Now we do also other tests for especially in Indian settings, markers of tuberculosis in pleural effusion. So these tests are ADA levels, adenosine, deaminase. If it is more than 40, it is suggestive of tuberculosis. And gamma interferon more than 140 picogram per ml, that is suggestive of tuberculosis. And of course we can also do the PCR in tubercular fluid, in the pleural fluid for TB. Now the diagnosis is made. Coming to the treatment, and treatment is very simple. Treatment of underlying disorder. And in cases of bacterial effusion, chest tube drainage. Chest tube drainage in bacterial cause, indications are, most important indication is presence of gross pus, empyema. Then culture positive, gram stain positive, sugar levels less than 60, pH less than 7.2. Indications, and these are in descending order of importance. That means कि empyema is the most important indication. Descending order. So with this we will finish the topic of respiratory system. So first slide of CLM, I think this will not be possible. You have to see in a recorded class. So you can ask your coordinator, they will put the recorded class, because now every slide, because it was a new page. SAG is the ascites, serum albumin ascites gradient, and that is a different topic of ascites, So Harrison topic for the selected topics, yes. Selected topic. To be read from the Harrison, starting from the respiratory system part 1. Remember, part 1 is equally important. Do not leave part 1. The topics to be read are dyspnea, cough, hemoptysis. So there they have mentioned most common cause of acute cough, chronic cough, and like this, most common cause of bronchial cause of hemoptysis, parenchymal cause of hemoptysis. They are given. They are important MCQs which come from that topic. And from the part 2 of Harrison, the table of interstitial lung disease, though some part has been covered, but the part which you have to read is the bronchoalveolar lavage fluid, findings of interstitial lung disease, and bronchiectasis. We have already done the causes, but you read the table of causes of bronchiectasis from the second part. Then from the endocrine part of Harrison, part 2, and important in part 2 is the reproductive endocrinology, because many questions are being asked. And in endocrinology also read the diabetes mellitus table of classification of diabetes. Each year question are coming from that table. What is the most common cause of MODY? What are the enzyme defect? So in that table a complete list of causes of diabetes, classification of diabetes is given. And also neurodegenerative disorder as well as CNS tumors. This will be the CNS part. Neurodegenerative disorder, CNS tumors from part 2 from the CNS. And from part 1 of CNS, the topics are headache, aphasia, memory loss, given in part 1. So they are concentrated, given all the causes, different characteristic feature of these are given in the CNS. So these respi we have covered, endo we have covered, CNS we have covered. So these are the parts that selected, highly selective topic from Harrison, highly selective topic of Harrison. So approximate level of pleural for clinical dyspnea, there is no level. It depends on the rapidity of filling. So it will not be a pinpoint ki 400 ml or 1 liter like this. And synpneumonic effusion is same as parapneumonic effusion. In effusion. So these are the parts. So gastric cancer associated with asbestosis, frankly speaking, no. Maybe a rare cause you can see in the surgery books, but in medicine book asbestosis is not mentioned as causing carcinoma of the lungs. So with this we will finish the medicine part. And if still after reading, if you have any queries or any doubts, you can email me, and my email address will be this. And I am Dr. Arvind. So most common CNS manifestation in Whipple's is dementia. All right. So